Emergency Medicine Program, MRChem Batch 1, and currently working as a medical officer in Maiman Medical Institute Hospital, Karachi. And today, I will warmly welcome you all to the most awaited, auspicious event of the year, which is Pakistan's first emergency medicine ultrasound course level 1. We will begin the event with the recitation of the Holy Quran, for which I would like to invite Dr. Yameen for the recitation of few verses from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد آمنت بالله صدق الله العظيم.
Moving onwards, I would now like to invite someone whose day and night efforts and hard work has brought forth such an organized event in front of all of you. He is the head of emergency department in the Maiman Medical Institute Hospital, Karachi, and has conducted many teaching and training sessions. And partly he has also started training of the BLS life skills recently, which is one of its kind. He is the lead organizer of this course. So let's welcome Dr. Mukhtar Ahmed Pathan for the opening remarks of the session.
अस्सलाम गुड मॉर्निंग एवरीवन। मैं जोश और वलवला नहीं देख रहा, कोई आवाज़ नहीं सुन रहा, बड़ी खामोशी है, वजह क्या थी? I will request everyone to please give a big hand of applause to Dr. Ashraf Suratia and to Dr. Syed Ali. Please, everyone. Thank you, sir. What should we do? अब लग रहा है कि आप वाकई आ गए and or you are really in, you know. So basically, emergency medicine ultrasound or point of care ultrasound, I must say that it has revolutionized the medicine, influencing almost every aspect and every specialty in terms of how care should be provided. So I think over the century, a clinician has been limited to primitive diagnostic tools, including flex hammer, stethoscope, etc. But now is basically we are seeing the portable ultrasound machine, or Dr. Ali's favorite tool, basically which is called handheld ultrasound machine. So it has basically really changed the world, you know. And now basically physicians are able to see and diagnose accurately. And not only they are able to diagnose accurately, but even they can treat the patient then and there, without any delay and accurately. So at the focus, your point of the ultrasound basically is the modality which is not only used in emergency department or in intensive care, but it's also used in labor rooms, and it's also in your operation theaters. So basically, London Global Emergency Medicine Program is basically bringing huge changes in our practices. And as far as LGEM is concerned, so we are learning a lot from this platform, basically through online trainings and through hands-on training sessions. और मैं इसमें एक बात ज़रूर कहूँगा कि डॉक्टर एश ने एक और चीज़ की है, ज़्यादती तो नहीं कहूँगा, अच्छी बात ही कहूँगा कि हमें टीवी से या मीडिया से या मूवीज़ और पार्टी से दूर कर दिया है। अब मुझे ये लग रहा है कि आज के इस ट्रेनिंग सेशन के बाद हमारे जो मोबाइल ऐप्स हैं, जैसे फेसबुक आ जाता है, व्हाट्सएप आ जाता है, ट्विटर आ जाता है, मैं पूरे यकीन से कहता हूँ कि इंशाल्लाह ताला हम इन तमाम चीज़ों से दूर हो जाएंगे और हमारे मोबाइल में भी सिर्फ एक ही चीज़ चल रही है और वो होगी पॉइंट ऑफ व्यू अल्ट्रासाउंड। तो मैं आपके और इसके अलावा जो हमारे मेंटोर्स हैं, जो हमारे टीचर्स हैं, जो इतने दूर से आपको सिखाने के लिए हैं, तो उसके दरमियान खलल में पैदा नहीं करूँगा, ज़्यादा वक्त नहीं लूँगा और मैं डॉक्टर इला से गुजारिश करूँगा कि हमारे मेंटोर और सीनियर्स को बुलाया जाए और सेशन का बाकायदा आगाज़ किया जाए। आप सबके आने का बहुत बहुत शुक्रिया। थैंक यू।
And now to deliver the welcome address. It's time to invite someone without whom I'm sure we would not have been able to reach up to this level. It was his idea, innovation, and thought process that today we are conducting Pakistan's first ultrasound course relevant to the emergency department. He's working as a consultant in NHS UK, is CEO and founder of the London Global Emergency Medicine Program, and is the program director of this course. For the last more than 10 years, he has been doing endless efforts to develop the field of emergency medicine in Pakistan, and especially to own the non-trainee medical practitioners of Pakistan. Indeed, he is an inspiration, he is an epitome of hope for all the medical practitioners of Pakistan. Undoubtedly, I feel extremely honored of having the opportunity to invite the pride of Pakistan, our true mentor, Dr. Ashfaq Suratia.
Thank you guys. Assalamu alaikum. Thank you very much for such a warm welcome. It's an honor. Thank you, Rida. Thank you, Dr. Mukhtiar, Haiti Pharmaceutical, for arranging this wonderful session. I'm glad that everyone is here. We were expecting 30 candidates, and 30 candidates are here. The purpose of doing this workshop was mainly to make sure that you guys get equivalent competencies which a UK trainee gets. When I started this program in Global Emergency Medicine, I was not planning to bring this workshop here because I never thought I will do it because it's not easy. You have to arrange all expertise, you have to bring people. So one of our friend in London, he said, you are claiming that your doctors will get equivalent training. How are you going to train them without ultrasound? I said, okay, we will take ultrasound there and we will train them. The price of this workshop in the UK is 350 to 400 pounds. It is equal to around 1,20,000 rupees. When I did, it was 350 pounds. But the level of teaching Dr. Ali is going to do is much higher than what we were getting in level 1. So I'm quite sure that today, by the end of this session, you will be able to get exactly what we got in London. Can we please have a silence, Ali? Please, all of you. Yes, I can't. Sorry about that. So I hope you guys will enjoy this session today. It's one of its kind. It has never happened in Pakistan before. Although there were some focus ultrasounds are happening, which is a good thing, but exactly as per the Royal College guidelines, I'm not sure whether this event has ever happened again before. So I hope, inshallah, you will enjoy this session today. Dr. Ali is already here. He's taken his time out. We flew together, and alhamdulillah, from Wales he came to London and then here. So please invite Dr. Ali. Warm welcome. Thank you very much, Ali, for coming. And let's start this workshop officially. Thank you.
Much obliged, Dr. Ashfaq. Really grateful to your kind words. We would now like to proceed further, and I would like to invite the lead trainer of this course, Dr. Syed Ali Ahmed, who is working as an emergency medicine registrar in NHS Wales and has travelled all the way from UK to impart his skills in ultrasonography. We have witnessed his enthusiasm to teach and passion to transfer his skills in the 100 emergency workshop which was held at Darul Sihat. Please, a big round of applause for Dr. Syed Ali Ahmed.
Assalamu alaikum. Thank you, Rida. Thank you, Dr. Park. Thank you, Dr. Mukhtar. I think there are many talented people and there are many learned people that I've come across. लेकिन किसी बंदे में उसका पोटेंशियल निकालना और स्पेशली जब कोई बंदा होप लूज कर ले, I'm sure you know this feeling. So I'm getting goosebumps to say this. I've probably lost complete of my motivation till I met Ashfaq Bhai, and he has sparked what I feel, what I was born to do. ठीक है, ये बहुत मुश्किल होता है. ये आपके शायद पेरेंट्स कर सकते हैं, कोई एक जिंदगी में किसी को मिल जाए. Then I traveled with him from Wales, from UK, and I've realized he's not the person that I thought what social media portrays. He's much more than that. ठीक है. And I told my parents कि last time जब मैं आया था तो मैं अशफाक भाई को एक different अशफाक को जानता था, और इस बार जब मैं travel करके आया हूँ, I know he is a very different person, much deeper than I could have even imagined. और मुझे बहुत बड़ा shock मिला कि in a very positive way कि what kind of person he is, and I'm entirely humbled and honored not only to be with him or be part of his team, but to see the future of you guys, how you're going to be, and you are the people whom I'm going to be working. So I've got no doubt whatsoever, all my efforts are actually going to replicate into 200, 300, 400, thousands of doctors. And today, we are very lucky. That's the first day, the first stepping stone of something which is very different, which is very big, as which everybody's going to have a look. And the world is going to see, as Ashfaq Bhai said. The world is going to see the quality, the energy, and the knowledge that we've got, inshallah. Okay. To start off, thank you, Dr. Mukhtar, for arranging everything, for running up and down, for arranging the ultrasound machines. Where imports have been banned, he somehow managed to get all those machines here, which is brilliant. Thank you very much for all the effort that you've done. And most importantly, every hour I used to message Mukhtar bhai, sir, ye ho gaya. Sir, Ali bhai, koi masla nahi, ho jayega, ho jayega. Then I used to tell Ashfaq bhai, ye ho jayega. Dr. Mukhtar hai, koi masla nahi. So he's our lifeline. Thank you very much, Dr. Mukhtar. To start off with our level 1 ultrasound course, I was trying to find an inspiration or a hair carrier, or why am I doing this? Okay, you have to always question its origins kahan se. So I went to search Quran, and this is what I found. And there were quite a few quotations or verses in the Quran. And one of these says, "And surely we bestowed upon David grace from us. O mountains, echo with him my praise." So the concept of echoes has been there 1400 years ago, and probably beyond that, since Prophet David. And this concept has been materialized into dolphins, bats, and other nature animals. And it's just for us to understand the science that's given by Allah. So आपके अंदर भी कोई ना कोई sign होगा. You have to find out कि वो sign क्या है and let it echo. ठीक है? So this is what I found, and I was quite inspired by this. Next is, so this is level 1 ultrasound course. I've worked quite hard to make it better, but I think this is who I am. Those who don't know me, Um, as a person, I'm a very simple person. I'm not very complicated, but this is what I've learned, and these are the institutes with whom I've been associated over the years, or still associated with. That includes National Imaging Academy Wales, where I am one of the 4 instructors who have taught the first ultrasound course, which happened a couple of months ago, 1 month ago. With various other hospitals I've been associated with as a trainee registrar, as a non-trainee registrar, and hopefully I'll become something in the future. To start off, this is my team, our team. Ashwad Bhai, I feel minnow in front of him, but hey ho, he's my teacher, so I would stand by him, and he will always be my teacher, no matter how much I've learned. Because it's not the amount of learning that you do, it's the catalyst that he does to you that transforms you into a different person. I think for me, that is what he did to me. So thank you very much. We continue on with the presentation. So our goals are in the next 5 to 10 years, we are aiming to train level 1 ultrasound courses to about 1,000 people, and hopefully we will succeed in that. Level 2 ultrasound focus courses should be conducted at least bimanually. These will be only open for GEM candidates who are level 1 certified or who have conducted our workshops. Yearly 50 ultrasound guided regional anesthesia. This is another aim that we are trying to do it. And to produce basically leaders in emergency medicine ultrasound. And I look at you in the next few years, you will be standing there conducting your first workshop. And this knowledge should spread. Okay? So, level 1 ultrasound code, what does it include? EFAS, ELS, AAA, vascular assessment, ultrasound guided vascular access, fascia block, which was initially non-ultrasound guided and then it became ultrasound guided. And the new Royal College recommendations are that you should know what Peng block is. You should not be able to do it, but you should know what it is. But I believe in the next few years, it's going to be part of the curriculum. So we'll learn that, how to do that as well. Okay? So EFAS, extended focus assessment using sonography in trauma. Any idea what this is? I'm sure you must have read the manual a bit.
4 pockets here, 4 areas, 4 windows.
If I ask you to summarize in one word, I would say in one line, it's a life-saving procedure. It does not matter how many quadrants you're seeing, as long as you're saving a life, that's what matters. If your aim is to save a life, it does not matter what quadrant it is, you're going to do it and you're going to save a life. That should be the bottom line. आज के कोर्स के बाद आप एक्सपर्ट्स नहीं होंगे, लेकिन आपको एक डायरेक्शन मिल जाएगी कि करना क्या है, और नेक्स्ट टाइम when you're going to see this patient, you're going to practice and you're going to be better and better at that. Is that okay? So EFAS has got some indications, basically abdominal trauma. It is rapid and repeatable. It does not require a stable patient. Okay? Whereas a CT scan, you need to stabilize the patient, shift the patient to CT, and then you get some idea. But in fast scans, you don't need to stabilize the patient. It's basically for unstable patients. आपने phone scan किया, उससे identify किया a certain pathology that is treatable, and you do that. Okay? It's not recommended in children till now, but maybe in the future things may change and things will become different. So, objectives: to find free fluid in the abdominal cavity, in the pericardium, and pleural cavity. Okay? And also to look for pneumothoraces. So, most clinicians, they say, will detect greater than 650 ml of free fluid. So you need to lose about 650 ml of free fluid before a person like me will pick it up. For people like Ashwad Bhai, 225 ml. ये है fluid, इसको laparotomy के लिए ले जाओ. ठीक है? So there's a difference between expertise of different people, because somebody's got experience of more than a decade, he will do better. I've got experience of 5-6 years, I'll probably do less. But that's all relative. I might get lucky, I might find something, but that does not mean that I'm less than you or you are less than me. It's just on the day if you find it brilliant. Okay? So, the equipment to use: low frequency curvilinear probe, set a depth of about 15 centimeters. आप लोग write नहीं करें इसको. Just leave the paper, pencil, just leave it behind. Just listen to me. Just listen to me. Don't worry about this. ये सब चीज़ें आपको इंटरनेट में मिल जाएंगी आपको basically. ठीक है? The concept of you guys listening to me here is to listen. अगर राइट करवाना होता तो मैं आपसे डिक्टेट कराता, बेटा लिखें, बट so change your mode of learning to slightly adult learning modes. Okay. Equipment low frequency होगा, depth 15 centimeter सेट करेंगे. TGC जो होगी वो आपको मेंटेन करनी है at a certain depth. ठीक है. और गेन के कॉन्सेप्ट को मैं एक्सप्लेन करूँगा जब हम लोग मशीन के ऊपर होंगे, क्योंकि रीड आप भी कर सकते हैं, मैं भी कर सकता हूँ, लेकिन समझाना मशीन के ऊपर है. Acquire and label the image, very important. Make sure you take the consent of the patient before you actually label them and ask them their permission. कि मैं ये इस्तेमाल कर सकती हूँ for my portfolio. You won't say no to it. So the 5 views that we have to look for. Basically, दिमाग के अलावा हर चीज़ देखनी है. ठीक है. Right upper quadrant, left upper quadrant, epigastrium, look for pericardial views and pelvic views. Okay? Right hypochondrial view. You have to place the probe in the right hypochondrium. It does not matter where you are. The only place you should not be placing is higher up. The fluid is going to go down the right side, lower side. How you need to place the probe? You need to place the probe slightly posteriorly. आप मुझे probe पकड़ा देंगे और एक मुझे volunteer चाहिए. Rotate the probe 30 degrees if necessary to look between the views. अब लोग जब ये करेंगे patient पे तो मैं आपको बताऊंगा. First we'll watch the video and see how it goes. So this is the area that we're trying to target. See the Morrison's pouch just below the liver and above the kidneys. This is the area we're targeting. So if you can imagine कि आपको probe कहाँ रखना है, it's literally at the lower end of the ribs. Okay? It's a very nice image that I found over the internet. This is where you need to have a look. Okay? Have a look again. Can I have you as a quick, really quickly? So ask the patient to put the hand behind his head. Okay? Looking at the probe. आगे नहीं रखना, slightly पीछे, directly, और फिर आप angle करेंगे, you can rotate it, and it's gonna look different. ठीक है? तो images आपकी depending on angle आएगी. आपने mostly posterior line रखना है, ठीक है? Anterior is line पे नहीं रखना, mid पे भी चलेगा. Try to reach as posterior as possible, but that's supposed to be the part of the body. Okay. Then we have got how we need to place the probe. This is where you place the probe, and this is what roughly you're going to see. Lights are good. Okay. See how it's transecting through the liver in the right hypochondrium, and it's looking at the kidneys as well. See? It's a very nice illustration of what it can look like. Next. And this is what you will see once you put the probe on the right hypochondrium. So the question is, does it look normal or not? You got 10 seconds to say yes or no. Does it look normal? Abnormal? Just say it. Doesn't matter if you're right or wrong. Normal. Why is it normal? So the green line that's being shown, that's the area you need to concentrate. ठीक है? When you see something beautiful, एक खूबसूरत गाड़ी देखी आपने, आपकी मेरी तो नजरें बिल्कुल उस पर फिक्सेट हो जाती हैं. ठीक है? So this is the area you need to. This is the beautiful spot that you can look at. There is no free fluid. If there was free fluid, it would appear jet black appearance. ठीक है? And this is how an abnormal image would look like. See the difference? Free fluid. अब तो अगर आपको ये देख लिया आपने, इस वीडियो को आपको दिमाग में आ गई है, आप यू कैन नॉट मिस इट. अंधे को भी नजर आ जाएगा कि यार ये तो फ्री फ्लूइड है इसके अंदर. ठीक. लाइट थोड़ी अगर बंद करने तो बहुत अच्छा क्लियर है. ये भी बंद कर. So you say, or what have laser pointer? Laser pointer. Thirty seconds is not. I wonder if I can increase the brightness. That helps. Is it any better? Here I was. Much okay. So, see this area? Yeah, kidney, just above that. And liver should appear something of homogeneous structure. It will appear black line over here. This is how it should appear. This is free fluid. Left upper quadrant. Similar placement, but slightly challenging, slightly more difficult because very posterior. Literally आपका probe जो होता है ना bed के साथ attach हुआ होता है. ठीक है? And this is where you interfere. Again, the same principle is applied. If you see free fluid, it's going to be very obvious. This is where you're going to place the probe. See how posterior it is? It's almost behind the posterior axillary line. And it's quite higher up. This is where you place the probe. And this is roughly where the images are being projected. And this is what you're going to see. Left upper quadrant here. Can you see? We need to have a look. What is this structure?
Spleen.
This.
Kidney.
Oh.
Kidney.
जबरदस्त. मैं एनाटॉमी में सप्ली आई थी. थोड़ा बहुत आते हैं. अच्छा. This is the free fluid where you're going to see. अभी यहाँ पे नहीं है. This is normal. Okay? This is what you need to see. This is very obvious. What is this? What is this? What is this?
This is the left impression. This is the left kidney and there is a fluid in between.
Yes. What's this?
Diaphragm.
Right. Exactly. Important चीज ये है कि unlike the right hypochondrium, which got almost no space above the liver, there will certainly be some space above the spleen. So you have to look for the area above the spleen and below the spleen, rather than the spleen and the kidneys. Okay, that's the most important part. The literature has shows that. Okay, quite often बड़े-बड़े consultants उनको नहीं पता होता कि भाई या किडनी और किडनी और स्प्लीन के बीच में सिर्फ नहीं देखना, ऊपर भी देखना है. Okay?
Black is the free fluid.
Black is the free fluid. यात्रा नेशनल में एक डॉक्टर साहब काम करते थे जब मैं हाउस जॉब कर रहा था. तो उनसे मरीज से पूछे थे कि मेलेना का कलर कैसा है ना, तो बेचारा नहीं बता पा रहा था। तो बेचारे बहुत डार्क कॉम्प्लेक्शन के थे, तो उसने बोला कि मेरी शक्ल के जैसा है। तो ये डार्क जेट ब्लैक कैसा है। ठीक है, मैं मरीजों से पूछता हूँ कि ब्लैक कलर कैसा, मैं लाइक माई हेयर। ठीक है, इतना काला नहीं हो यार मैं। ठीक है, तो दिस इज व्हाट यू नीड टू सी, जोक्स अपार्ट। Next, pelvic views. Retrovesical recess in men and pouch of Douglas, rectovaginal pouch in females. Basically, any area between the organs, we see a jet black thing. That means that's not a very happy person. Okay? So be very careful. Longitudinal views in or horizontal views in. Pelvic view, this is roughly how we're gonna place the probe. See how inferior the probe is? It's literally just above the pubic symphysis. So you have to go really down to explore the pelvic area. मैं कोई भी चीज़ डिटेल में नहीं बता रहा हूँ. As we go and demonstrate on someone, I'm going to explain the nitty-gritties and little details of everything as well. ठीक है? The important thing is जब भी आप fast scans कर रहे होंगे, the pointer should always be directed towards the patient right or towards the patient's head. A couple of exceptions exist. I'll just explain to you. Okay? See this? You can scan like this. Next image. This is how this will look like. यामीन भाई बताइए मेल का है फीमेल का है? क्यों?
ये जो ये वाला है ना, इससे
see this? Then where is the rectum? No rectum.
जो ग्रीन ऐसे क्यों बन रहा है?
Hartmann's procedure हुआ निकाल लिया इसका rectum. इस image पे अच्छा नजर नहीं आया. It will be flat slit. If the empty is rectum, this is what you're going to see. So don't misdiagnose or don't think that this is a rectum. This is the uterus. And if you look for free fluid above and below. Okay? Next. समझ आ रहे हैं? Is the image clear? Are they clear enough for you? Oh. Do we do anything else? Okay. You see some free fluid here? Lots of it. अगर ये bladder की जितना अगर में नीचे कुछ नजर आ रहा है ना, definitely दो bladder तो हो नहीं सकते. It's definitely going to be free fluid. Okay? Next image. This is the sagittal view. See how you're fanning the probe, medial on each side. The probe projection of the light, projection of the beam is vertical, sagittal. Okay, and this is what you can see. This is the bladder. This is a bit of free fluid that you can see. And ये मेरे ख्याल से मेल का है, लेकिन यहाँ पे शायद फीमेल दिखा दिया मैंने. I can see probably a uterus there as well. Anyways, the point is you're not here to diagnose इसका uterus है या नहीं है. किसी की अगर hysterectomy होगी, that doesn't mean तुम uterus को find कर रहे हो. All you need to do is find free fluid. Okay? Is that clear? Anything similar to the bladder? Have a look out for free fluid. Okay? Jet black appearances. This is what you want to look for. Very nice, clear free fluid here in this patient. See this? This area. Yes. Let me show you this area. Free fluid. Okay? अभी शायद बहुत मुश्किल लग रहा होगा, but once you place the probe every day, when you see so many normals, when you see an abnormal thing, you will know it's abnormal. You will not necessarily know the diagnosis, but you will know that something bad is happening. Okay? Next. Pericardial probe. It's here to review things that fast scan should look for. We have to look for pericardial space and the free fluid in there. We have to look at the ventricle size, ventricle contractility. Does it look like a happy heart or is it struggling? Simple. No rocket science involved in it. Okay? Sub-xiphoid views and long axis parasternal views. Okay? This is what we need to do. Again, I'm going to explain how to hold the probe, which direction should the pointer be. You don't have to stress about that at the moment. ठीक है, जैसे हम लोग किसी पेशेंट पे ह्यूमन बॉडी पे करके दिखाएंगे, आपको बताएंगे पॉइंटर किस तरह होल्ड करना है, क्या इमेज लेनी है आपको, ठीक है? Because quite often machines के वो pointer oriented नहीं होते हैं the way you want to orient. Right, left होता है, left, right होता है, then you get confused. So that's why I don't want to stress about where the pointer should be. Okay? But as a general rule, except for pericardial views, when you're doing the fast scan with a curvy linear probe, the pointer should always be pointed towards patient's right or patient's head. इतना भी अगर आपने आज take home message कर दिया ना, that's good enough for a first day. Okay? Because there's lots and lots of things that you have to learn today. Sub-xiphoid view. This is how you're going to look like. Yeah, you have to place the probe literally almost parallel to the patient. लोग क्या mistake कर रहे होते हैं? Angle at 45, angle at 35, 30 degrees. This is not going to work. You have to place the probe literally parallel to the patient. घुसा रहे होते हैं पेट में, मरीज चीख रहा होता है. You don't have to do that. It's not as complicated. Again, जितनी बार करोगे उतना पता चलेगा. कंसल्टेंट सीख लेते हैं, लेवल 1 कोर्स कर लेते हैं, साइन ऑफ हो जाते हैं, 10 साल तक मरीज को हाथ नहीं लगाते हैं. You have to put the jelly on the belly every day to become successful. आप साइकिल बचपन में चलाई आपने, अब मेरी एज में करके चलाओगे 10 साल बाद तो आप कॉन्फिडेंट नहीं होगे, लेकिन as you go along you'll become confident. You're not going to forget how to hold the probe, but you become more confident at identifying the structures. And this is how the sub-xiphoid view is going to look like. Okay, so basically you're scanning through the liver. Liver is your friend. Okay, this is the liver. This is the right side of the heart. This is the left side of the heart. Okay, I'll show you. Liver. This is liver. Right side of the heart. Left side of the heart. Okay. Now I'm going to ask you a question. What chamber is this one? Atrium. I show it. No problem. ये liver है, ये heart है, right ventricle, right atrium. ठीक है, अब देखिए ना, ventricle पहले आ रहा है ना, फिर आपका atrium है, ठीक है? This is how you can look like. Okay? Next. इस image को आप पट्टा मार लें इसका. This is how the first structure is going to be the right side because the liver is at the right side. Okay, once you identify the liver, then you look at the heart. What side you're going to look at? It's going to be the right side. It's close to the liver, it's always the right side. इतना भी याद कर लेना, इतने समझ लें. That's a good step. Good foundation. ठीक है, solid foundation में चाहिए. ABC नहीं आइए, आप article लिखना चाह रहे हैं. This is the ABC of fast scans. ये basics है. अगर ये चीज़ बन जाएगी, you never get confused. या ये right ventricle, left ventricle है, probe position right पे है, left पे है, pointer right पे है, left पे है. It's all irrelevant. Okay, you're not sonologist, you are EM physician. There's a difference between them. You're here to save a life, make a quick decision based on the clinical assumptions and pre-test probabilities, and this is what you're going to find out. Okay? Next. What do you see here?
Struggling heart. Right side and left side.
Very good, struggling heart. I like this. I like the term. Not very specific, because you're not a cardiologist, you're not a sonologist, but you know that it's happening. Okay? ये pause हो गया क्या? चलो भाई. So what do you see here? What do you see? What's this? Most likely liver area. What's this? Right ventricle. Right ventricle. Right is always right. Okay? Left ventricle. Right atrium. Left atrium. Okay? So what is this black like my face? You'll never forget that now. Pericardial fusion. Okay? If you see a black structure similar to this outside the heart, which is more than a stripe of your hair, something is wrong. Okay? Next. This is long axis view, perhaps a long axis view. The pointer should be towards the patient's right shoulder. Okay? And this is what you're going to see. See how your beam of sound is piercing through the heart? See that? This is my favorite view. Most complicated लगती है लेकिन सबसे ज़्यादा इसमें चीज़ें आप इससे identify कर सकते हैं. If you hold it at the right place. Everything that we're doing in E-fast has got an F to it. If you do it properly, if you do it right. ठीक है? अगर एक दो मरीज में आप identify नहीं कर सकते, that doesn't mean that you are bad at it. It's just that human anatomy is so variable in different person. You can't control that. But the more you do it, I can assure you, the better you will become at it. Okay? So what do you see here? What's this side? What's this? What's this? What's this? कोई भी structure identify हो रहा है heart के अलावा? किस से? Yes, valve. Yes. Which one is this one?
No, the flapping जो है.
Yes, this one. Yeah, nice. ये कौन सा valve है?
Posterior.
Mitral. Mitral. ये कौन सा है? ये और क्या है? ये और क्या है? ये और क्या है? ठीक है? ये क्या है? Right side of the heart. Don't have to worry about ventricle or atrium. Don't have to go in that. Okay? Contacted देखते हैं ठीक है? Are you sure? रिब ऊपर होती है नीचे होती है? ऊपर होगी ना? Ribs ऊपर होंगी. But you should understand that ultrasound beams don't penetrate the ribs. ठीक है? ये rib नहीं है pericardium है. Posterior wall. Inferior wall, sorry. See? The way it's going through, right side. Okay? It's going through and through. Right ventricle. Atrium नजर नहीं आता. ठीक है? Left ventricle. Left atrium. Aortic outlet. ये चार चीजें आपने देख ली. That's more than enough. अगर कोई एक्स्ट्रा चीज आपको देखनी है ना, एक रूल ऑफ थंब है. This should be equal to this, should be equal to this. 1:1:1. Oopsie. अपग्रेड नहीं करना है. Sorry about that. Five minutes break. Any questions so far?
Yes, I have a question, please. Sir, whenever you go for echocardiography, you put a probe and they don't put time as you do. Painful होता है, समझना होती है. This is sir stabbing, like they are stabbing it.
अगर आप तकलीफ दे रही हो ना, you're doing it wrong.
सर मैं तो नहीं देती सर, जो इंडिया कर होती हैं. तो सऊदी में जो है ना, देखो पैरेलल नहीं करते.
अब सीख लेना better.
हाँ सर, उनको बोलेंगे सर वो पिटाई कर रही. सर एक तो परपेंडिकुलर रखती है और इतनी जोर से रखती है जैसे स्टैब कर रही है. सर अब उनको मैं बोलूँगी कि वो गलत कर रही है, तो सही से करें.
वो बोलेंगे सही करके बता दो.
बाहर निकलो.
ये तो बताओ कि बेटा इसका
हाँ नहीं सर, अब
बोला आप अगर मरीज को पेन कर रहे हैं.
जैसे सर मैं आप अगर डॉक्टर टेमिना वेरी एक्सपीरियंस लाइक अभी की नहीं जमाने से करते जा
कोई एक शब्द बोला.
रही
Experience is not equal to competence.
एग्जैक्टली सर. मैं अंदर से पेनफुल होती हूँ, मतलब हेल्पफुल है. थैंक यू सो मच सर. मुझे पेनफुल होता है वो परपेंडिकुलर स्टैबिंग. सर लाइक फोर्सफुल रखने से इमेज अच्छी तो नहीं देंगे, इमेज तो वही आएगी.
The first rule is to cause no harm. If you cause no patient pain, you use this.
Exactly, I don't know why they are doing this. बेंडिंग के लिए होता है ना, तो पैरेलल बेंडिंग
So as usual, the master of all is trying to help us out, Dr. Ashwal, because I've got no idea how computers work. कोई और क्वेश्चन? any other questions? Any stupid question? Any intelligent question? Long distance parallel. You're gonna go in between the ribs, roughly second, third, fourth ribs. Okay. Yes. You're gonna अगर इस वाले प्रोब से कर रहे हैं towards the right shoulder. Okay, long axis parasternum, short axis parasternum. Then you start the parasternum. More on the left. You're being introduced to the game is easy. What you got angle to sternum. After breast can have sternum. Because all you need to do is to reach below the sternum. Okay? Hello? Just below the sternum. Just below it. Just up. Huh? Yes, currently. Any other questions? Any other questions at all? तो अशफाक भाई ने ट्रैवल के दौरान मुझे ना अपनी सीक्रेट ऑफ लाइफ बताया। हो और फिर इसके बाद उन्होंने मुझे एक जुमला बोलते थे हमेशा, सब बता दूं। मैंने इनको सोने नहीं दिया, मैं इनको बस नॉन स्टॉप आई वाज डिस्कवरिंग मोर एंड मोर एंड मोर, और जितना मैं डीप जाता जा रहा हूँ मैं कहता था ओह माय गॉड। तो ये मेरी OMG वाली सिचुएशन आई हुई थी। बॉस अपने लिंक भेज दीजिए।
So I have one more question.
Yes.
So probe, जितना भी force लगाएंगे, there is nothing to do with the force, right?
Sorry?
There is a probe पे जितनी भी force लगाएंगे, there is nothing to do with the image. तो यहाँ पे जो हमारे डॉक्टर्स होते हैं, वो probe पे इतना force लगाते हैं कि image अच्छी बनेगी. So there is nothing to do.
देखो, listen, there's no such thing as जितना force लगाओगे उतनी image अच्छी होगी, नहीं.
Exactly.
Air is the enemy of ultrasound. The reason you put jelly is to have an interface through which sound will travel faster. Okay? पुराने ज़माने में क्या होता था, जब जंगें होती थी, so they used to listen to the sound of horses by listening to the ground. घोड़ों की दौड़ की आवाज़ आती थी, right? Air में नहीं travel करती थी. इसी तरह आपके echo waves जो होती हैं, they are more better through liquid rather than air. ठीक है? So अगर बीच में space आ जाएगी, हवा आ जाएगी बीच में, तो transfer ही नहीं होगी waves. Okay? So there is no such thing as forcing the probe on a patient. This is wrong. Just have enough jelly to have a good interface between the patient and you. Okay, so this is wrong.
This is absolutely wrong.
And you got a reason for it now.
No.
And explain it to them next
Yeah,
time. Okay?
I'll tell them properly.
Sorry guys, ये हम लोग first time कर रहे हैं. मीटिंग आ गई है, लेकिन वो पूरा लिंक पूरा खुल रहा है. हाँ, आपको सेपरेट कर सकते हैं. इसको मैं सेट करूँगा. Okay, boss. Okay. Now you have to allow me as a host. So, beautiful. So screen पे नहीं आ रहा. Allow me to become the host. हो गया? ठीक है, वो that's my question. Okay, so this is what we are looking at, parasternal views, a long axis parasternal view. Okay, and this is probably my favorite because इसमें मैं बहुत सारी चीजें देख सकता हूँ. इसमें मैं check कर सकता हूँ right side enlarge है as compared to left side. इसमें आप check कर सकते हैं there is any pericardial effusion. ठीक है, this is the mitral valve and it should be touching the septum. Okay, अगर septum को touch नहीं कर रहा है, it's not opening enough. ठीक है, inflow to the heart is not good enough. Okay, so simple things and common sense hai, and this is what you have to look at. Okay, next. So the pleural space and the presence of the pleura or absence of pleural movement. This is what you have to look for in pneumothorax. मेरा best friend था Nabi. We were school friends since the age of 3. He died the day I landed in UK, and so this thing, the story of ultrasound means so at It means so much to me at a very different level. He died at the back of an ambulance with an asthma attack with a pneumothorax. Okay? On the day of the wedding of his brother. Okay? And it was the same day that the first time I landed in UK. And the first phone call I got from my dad is that Nabil died. And I was in shock. I didn't cry, I didn't do anything. But I was in questioning myself, what's the use of my existence? और जो first time मैंने जो ever कोई चीज़ diagnose की थी ना वो pneumothorax थी on ultrasound. And that just made my life so good or purposeful. Because this is the reason probably what I'm going to be doing in the future. The first thing that I diagnosed was pneumothorax. It's very easy. All of you can diagnose after today whether it's a pneumothorax or not. Simple as that. There's no question about it. This is the first week of my handling the ultrasound probe, I diagnosed a pneumothorax. And that just answered my question. Probably this is what I meant to do. Okay, life आपकी simple नहीं होती, but you should learn from those tragedies of life. Okay, next. Lung views. The green ones are the ribs. Then you see the pleura. Okay, and this is the pleura. And this is where you need to put the probe. This is the head end, this is the lower end. In between the ribs is what you're targeting. You see the shimmering line in between, that's the pleura, and that should be moving. Okay? See how it's moving? It's not static. And this is what you need to look. This is the chest wall, these are the ribs. In between the ribs you have to look. If it's not moving, most likely, not definitely, most likely it's a pneumothorax. Okay? If it's not moving. This is normal. We'll show you on a human being, on the body. We'll show you कि normal कैसा है. Once you identify the normal, जब abnormal देखेंगे आपको पता चलेगा यार this is not moving, this is most likely pneumothorax. And अशफाक भाई ने सिखा दिया आपको जब pneumothorax होगा या tension pneumothorax होगा आपको क्या करना है. Right? We've learned this in the 100 EM procedures. Okay? आपकी basics अच्छी होनी चाहिए. What we are here to teach you is the basics, the very basics. अगर वो आपको पता चल जाएंगी, उसके ऊपर आप build करेंगे through experience as you go along, as you learn along. ठीक है? Next. Any questions so far? Any questions? No questions? Come on, yeah, कोई तो सवाल करो यार. Increase my knowledge. Ask me something that I don't know, and I'll come back to you with an answer. Maybe not today, maybe later on tomorrow, but I will give you the answer. You have to ask me those questions so that मेरी knowledge बढ़े. In the next 4 years, 5 years, मैं चाहता हूँ सब लोग मुझसे सवालात पूछें या मैं आपसे सवालात पूछूं तो आप मुझे उसका आंसर दें. मेरी knowledge increase करो.
We can also look for diaphragmatic paralysis or with ultrasound.
Yes, we can look for, but that's not part of the fast scan or that's not part of the level 1 course. Okay, we can look at diaphragmatic paralysis. जब supra interscalene block करते हैं ना हम लोग for shoulders, ठीक है, shoulder reduction के लिए, तो we always look for the diaphragm. Both sides of diaphragm are moving. क्योंकि अगर आपने right side पर interscalene block किया है, left side का उसका diaphragm paralyzed हुआ है किसी तरह से, आपने right side की phrenic nerve block कर दी, वो patient मर जाएगा. It's good news. Any questions? Anything else? Ventilated patient में ना, that's the answer that I was looking for. कि कौन सी ऐसी condition है जिसमें वो move नहीं करेगा? Ventilated patients में very little movement or no movement. Okay? और अगर pneumothorax है तो पता चल जाएगा कि एक लंग move कर रहा है, दूसरा लंग move नहीं कर रहा होगा. So that's a contraindication for intubation. Okay? First put a chest vein in.
I think 2-3 candidates late भी आए और I think एक refresher slide go through अगर आप बता
बिल्कुल कर देंगे सर, कोई मसला नहीं.
ताकि इनको मेमोराइज हो जाए कि अब हमने कैसे करना है, क्या करना है, just to the point.
ठीक है?
From one slide one, I think Dr. Siddiqui just came.
कौन लेट आया है जिसमें मिस्टेक हो? No problem. Or anything else? Anyone else?
But I think it will be useful for everyone.
Yes. No problem. Again, my computer skills are not the best. I'm trying to do my best. We were talking about fast scans उनके use क्या है e-fast, ठीक है? What are the views that we need to get? I'm not going into the details of probe position कैसी होगी, वो हम लोग patient में बताएंगे, and that's the main मकसद of this teaching. For abdominal traumas in unstable patient, ठीक है, to detect free fluid in the abdominal cavity, in the pericardial cavity, in the pleural cavity, and also look for pneumothorax. These are the fast objectives. And I always say, जब objectives lose हुए हैं ना, to always think, how can I save the life of this patient? That's all you need to think of. अल्लाह ने आपके लिए रास्ते बना देंगे, ठीक है? हम लोग basis आपकी बना देंगे, the rest you will do it on your own. In a few years time, आप लोगों को इतनी चीजें सीख जाएंगे, आप कहेंगे यार, हम लोग क्या थे, क्या बन गए? Inshallah. Most clinicians will detect about 650 ml of free fluid. Some can detect it to 200. If you do it for enough years, आप बहुत कम fluid भी detect कर लेंगे. Especially UK में, as compared to Pakistan, patient बहुत early present कर देता है. तो बहुत small amount of fluid भी हम लोग को देखना आ गया है. आप लोगों को जब जैसे आप probe रखेंगे ना, you will find it because most likely the patient that you're going to receive is going to be very unstable. उसके बाद resources नहीं होंगी, वो CT scan में जा सके, उसके पास कुछ भी नहीं होगा, टाइम भी नहीं होगा, and you are going to be the large savior. Remember this thing, never underestimate your power. ठीक है? Accuracy इतनी होती है इसकी, curvilinear probe होता है, set at 15 centimeters depth roughly. Always require and label the image. Make sure you take the consent of the patient. Little things, make it ethical, moral, और सबसे important बात, pain नहीं हो patient को, pain नहीं होना चाहिए मरीज को. Next, sorry. These are the views: right hypochondrium, left hypochondrium, pericardial views, and pelvic views.
थोड़ा इसमें कमेंट भी कर दें ताकि वो
मैं डिटेल में आऊँगा, ठीक है? Right hypochondrial views में आपको just anterior to the posterior axillary line या mid axillary line पे रखना होता है probe, okay? Longitudinal होगा. In fast scans, almost all the image pointer will be either towards the patient's head or the patient's right side. ठीक है? Make sure the orientation of the probe is matching the screen. Okay? I'll explain what that means later on. This is the right hypochondral view. The area that you're targeting is just above the kidneys. Okay, boss? This is what you're looking at. Morrison's pouch. It may all seem very difficult, but believe me, it's very easy. Very easy. And this is another way to look at where your beams are focusing. See the beams? These are like the Chinese fan. Okay? These are like the beam of light, like the Chinese fan. This is how they will look like. And you're piercing through the right side, you're going through the liver, and looking at the space between the liver and the kidneys, right hypochondrium. Okay? And this is roughly the area we're looking at, exactly the area you're looking at. You're looking between the liver and the kidney, the green line. Okay? This is the area. This looks normal because there is no free fluid. And how does free fluid look like? Black. Sorry, image is projected पे इतनी अच्छी नहीं आ रही है, but the place at the top is the liver, the place below is the kidney, and in between the kidney there is a black free fluid. अगर एक और अच्छी left hypochondrium के मतलब अच्छी view है. Left hypochondrium, similar principle, but it's more difficult. You have to go slightly higher, and the probe should be almost, in fact, exactly kissing the bed of the patient, very parallel to the bed of the patient, almost posterior to the posterior axillary line. This is the key to success. अक्सर लोग left hypochondrium देख ही नहीं पाते हैं, because they are just not making enough effort. Okay? And this is what you're going to see: left hypochondrium, left hypochondrial views. You're scanning through the spleen and the kidney. Okay? This is the left upper quadrant normal view. The area above is, this is the kidney, this is the spleen, this is the area you're looking for, and you also have to look at the area above the spleen as well. This is most likely where you find the fluids. Okay? Next. See the free fluid? Diaphragm, spleen, kidney is above the spleen. I can bet on it, 90-95% of people in EM don't know this. They have to look above the spleen as well. Okay? Next is the pelvic views. In the pelvic views, you have to put the probe in a transverse plane and in a sagittal plane, and you have to look for the basically free fluid around the rectum, around the uterus. Make it simple for you. Pelvic views. This is where the beam is going, like a ray of light. It's going transversing through the bladder, and this is what you're going to look at. This is going to look like bladder. We can all identify as black. Anything outside the bladder is this is the uterus, and you have to find the free fluid here or here. Okay? Next. Transverse views, again, bladder, whatever this is between, that doesn't look normal. Okay, that's black free fluid. Okay? Next. This is a sagittal view. When you're doing the sagittal view, you're spanning the probe right and left rather than up and down. Okay? Look at how the probe is going to move. It's going to move right and left, and this is what you're going to see. Again, you have to look for free fluid. You don't have to diagnose whether this person has got a uterus or not. It does not matter. Anything black outside the bladder, think abnormality. When I say black, it should be jet black. Okay? So there is some free fluid. Oopsie. Some free fluid. Here, here it is. Here. This area. See this? Whatever it's going to be, it's going to be very obvious. अभी images प्रोजेक्टर की वजह से इतनी अच्छी क्लियर नहीं आ रही हैं, but we can do on a person. You say यार ये तो बहुत ही easy है. आप बहुत confident जाओगे यहाँ से इंशाल्लाह. ठीक है? This is the pericardial views. Two views you have to do. Subxiphoid, at least long axis view. Subxiphoid view. Place the probe almost parallel. See, almost parallel. See the little movement that's going parallel to the body. Okay, you don't have to dig it in the tummy. Just hold it parallel. Mareez ko pain nahi hoga. And just press it down, literally a centimeter, the width of the probe, 2 centimeters down, and you'll see the pericardial views. Okay. And as you're going to the subxiphoid view of the pericardium, this is the liver, this is the right side of the heart, this is the left side of the heart. Okay. And what you're looking for is this space, pericardium. कितना clear है यहाँ पे? और यहाँ पे कोई free fluid नहीं है, jet black appearance नहीं आ रही आपको. Okay. And how the abnormal heart will be looking like? See the free fluid outside the pericardium. It almost looks like a 3-chambered heart. Okay. You always go to the liver, then the pericardium, then the right side of the heart, then the left side of the heart. This is the long axis parasternal view. The pointer will be pointing towards the patient's right shoulder. Okay? And this is what you can look at. The right ventricle, left ventricle, you don't see the right atrium in this view. And the left atrium, the mitral valve, the aortic valve, the aortic outlet, this, and this area should be 1:1:1. If there is an abnormality, there's strain on the heart. If this mitral leaflet is not touching the septum, that means the heart is not happy. Okay? These are very basic things. I'm not going into the details. We don't have time to go into the details. We don't have to know the details for level 1 as well. Just very basic things. This is the E-fast, extended fast. We have to look for the clear space in between the ribs. Okay? And we have to look for movement of pleura. This is the rib, this is the pleura. There is a moving image. The next one. In the lung views. You need to divide the lung into 4, each lung. Upper quadrant, lower quadrant, right lateral upper, right lateral lower. You need at least 2 quadrants, or you need to scan all the quadrants to look for pneumothorax. You can't say कि यार ऊपर रखा है ये move नहीं कर रहा, क्या पता pneumothorax नीचे हो. Okay, so be very careful. Make sure you scan all the areas. Okay, it may be a small pneumothorax. This is normal. This is the glistering membrane, the pleura. This is how it's going to look like. This is the rib. This is the chest wall. Simple. Okay? This is called lung sliding. Absence of lung sliding is most likely, not definitely, pneumothorax. Identification of a lung point is what is diagnosed as pneumothorax. I will explain you what a lung point is. It basically is a junction where the lung is moving and not moving. Okay? The pleura is moving versus not moving. That's for the lung point. Okay, boss? Happy? We'll take 5 minutes break and we continue on. Just 5 minutes.
So, I hope you guys enjoyed this session.
Yes.
So ultrasound is the future of medicine. There is no physician without ultrasound. So in upcoming days you will see there will be a clear demarcation between doctors with ultrasound skills and doctors without ultrasound skills. So it's going to happen. And we are actually thinking and planning to introduce ultrasound at undergraduate level, at final years, to show them just the anatomy of how the liver looks like and how, so that they build this interest before they go out of the medical school, and then they can take it further. I'll share 2 important incidents which we picked with the ultrasound. We had a lady, Asian lady, she was a rare sea passenger, very small, 40 miles per hour mechanism of front end collision of the car. Everyone was fine, patient came in A&E, all other passengers were good. She wanted to go home as well. We did a basic blood test and everything was fine. The SHO came to me and said, she looks fine, all bloods are normal, very simple mechanism, abdomen is soft, no tender, no guarding, no rigidity. I said, okay, what's the blood pressure? She said, 110 over 90. I said, pulse pressure is a bit low. How old is the patient? She was 65. For her, this blood pressure is very low. She's known to have hypertension. So usually people above 65, the blood pressure of 110 should alarm you. I said, okay, let's put the probe. We put the probe and I found the free fluid, a very small amount of free fluid. And I was thinking, is it an artifact? Is it a free fluid? We did the CT scan and there was a small mesenteric tear, very small mesenteric tear. And she went for a surgery and she had a laparotomy, she survived. There was a very high chance we could have sent her home because everything was ready. Family was ready, we would have sent her home. I had another girl, she was a young 18-year-old, she was just joined NHS as a healthcare assistant. And she was doing bloods and all of a sudden she just collapsed. So, everyone thought, all the other nurses thought this is vasovagal syncope and wake up and all this. She came back to senses again, she was conscious. I said, no, something is not right. And we put the probe and she had a free fluid. Actually, she was ectopic, ruptured ectopic. And you can't believe it. Ultrasound will save so many lives it will save, you can't believe. Our future projects are hospital at home, which you guys will run in the show, and we will provide you ultrasound machines in your city, in your region, where you don't need x-rays and stuff. You will go and you will do A, B, C, D, record the images, it will come on computer, we will see and we say, okay, do this. So this is just the beginning of your life. There is a lot more coming for GEM. You're already very popular. GEM program is already very popular. First batch is already very popular. I still remember a patient, and I shared, I don't know if you're on my Facebook, There are thousands of stories actually, it's not just one story. For ultrasound, everyone has some story to tell you. We shared it on the Facebook as well in 2016. If you go and see my profile, there was a lady 60 years old. She came with a history of small epigastric pain. They did the ECG, drops were borderline, and they thought that this is NSTMI. Second drops were also borderline, and they treated as NSTMI. They gave her Clexane and everything. Spoke to medical team. Medical team said, "Okay, send her home. We will see her in AMU, in ambulatory care." She went home. After 2 days, 3 days, she came again with abdominal pain, epigastric pain. So, as a consultant, when patients when they come second time, they always in NHS there's a rule: if the patient reattends it, someone senior has to see them. So of course that patient came to me now because I had to see. I said, and I do so many ultrasound. I just put probe to everyone. And I'm sure once you will learn it, you will get the skill. By the time you will be more senior, I think ultrasound machine will be in your phone, and it's already there. It's already there. A lot of people are using it. In America, no one is using stethoscope now. Stethoscope is a deception now. एक धोखा है कि it's gone out. So we just put a probe and look how the valves are and how's everything. So that patient, we just put the probe. She was treated as NSTMI. She was given Clexane and all those things. A complete package of ACS. When I looked at her abdomen, she was having an aortic dissection. There was a flap. If you go and watch that video, it's still there. That patient survived. We sent her to the cardiothoracic and she survived. Second time she came, luckily she got saved. There was a young patient, again I shared the story, very interesting story. Heavy alcohol intake, he didn't know anything and he just said, I got epigastric pain. Doctor sent that patient home with the omeprazole. He went home, he came back again on the same day. As a reattender, we had to see them. I was thinking, he's a young patient, Ash, no need to do ultrasound, but you have an itch to do it. Once you learn it, you have it. I said, let's do the ultrasound. I put this probe on, I could see some foreign body here in the stomach. I said, well, how? It doesn't look nice. Something is wrong. We sent the X-ray. There was a huge bottle of beer inside. So apparently, the story was that he had met some girls and he didn't pay and he was drunk and they put the bottle of beer through his bottom back and it came up to here, the liver. And I also shared that story on my profile. So ultrasound can do miracles. I picked up few retinal detachments, lots of torsions. All the young boys, we put these probe on, test this, you can differentiate between orchitis and with the Doppler you can actually see. So there's so much to teach. This is just the one day. We cannot teach you everything, but at least you will have flavor of this, You can actually send patient home quickly by doing the DVT scans. We will be giving you a logbook after this session. Dr. Ali has prepared a logbook. Every one of you after this workshop, you have to do the college requires you to do 20 aorta scans, 20 fast scans. 10 you have to do vascular, 5 ultrasound guided vascular and 5 echoes. That will be a logbook before you come to UK. Make sure that you have this logbook in your hand so that you can apply for training program. Because without that you won't go further. There's a lot more to come forward. So it's just day one. I hope you guys enjoyed.
Yes,
Alright, good. So it's your tea break, I think. So let's do a tea break and we'll meet again. Thank you.
So we'll be back and inshallah whatever.
हमारे फाइल चल रही है
Thank you so much for my
टीम मीटिंग चलने देना तो मॉर्निंग के बाद
areas they specify whatever you want that to serve. Can you see the difference? Yes, I can. Yes, what is acceptable? मैं देख बाहर निकली तो किसी को मुझे ना मैं कहती हूँ कि ऐसे डॉक्टर पे मेरे बाकी
Right close to it. Any questions?
Hello, hello. Hello, testing. Hello. One, two, three, two, one. Hello.
Any questions? Anything else? No questions? Sir, आपसे बोला आप नहीं मिल
हाँ अभी प्रैक्टिकल में ही है।
ठीक आप कैसे आप खैरियत से ये बेगम डॉक्टर नायला बच्चे सब खैरियत से जी खैरियत से आपका सफर गुजरे आपका वर्कशॉप गुजरे नहीं मैं इधर कराची में आई एम बलूच आई बिलोंग टू बलूचिस्तान रहते कराची में हम लखनऊ जाते हैं अच्छे नहीं है बिल्कुल मैं अभी आपको ले जाती लेकिन पानी की वजह से थोड़ा हालात अपसेट है
डॉक्टर मुख्तार सर सबको अंदर प्लीज।
मेरे तो आप उधर मैंने आपको ऑफर की थी आके अपना ये सेटअप टाइम करेंगे
जरूर एक बार चक्कर में लगाएंगे इंशाल्लाह देखिए
इंशाल्लाह
सर डॉक्टर शॉप सर्विस स्टार्ट।
Yes, I think you can start. We are already.
Okay, next one we are going to learn about is Triple H. Before we start off again, I think हम लोग as a com inherently बहुत ही thankless हैं, उसमें शायद मैं भी हूँ। तो before we start, Dr. Asif Iqbal, CEO IQ Pharma, would you like to have some word with us, please? Clap, please. Thank you.
थैंक यू डॉक्टर अली। बिस्मिल्लाहिर्रहमानिर्रहीम। जी मेरा नाम आतिफ इकबाल है। आई एम CEO हाईक्यू फार्मास्यूटिकल्स एंड हाईक्यू फार्मास्यूटिकल्स इज़ रियली ऑनर्ड कि आज अशफाक साहब, मुख्तार साहब, अली साहब ऑल द वे फ्रॉम लंदन इधर आए हैं और इस इम्पोर्टेंट टॉपिक के ऊपर एक सेशन दे रहे हैं। तो आई एम ग्रेटफुल टू देम एंड रियली ऑनर्ड कि हमारी जगह इन्होंने सेलेक्ट की थी यहाँ पर आपको ट्रेनिंग दी जाए। एंड आई होप कि ये ट्रेनिंग जो है आप लोगों को बहुत ज़्यादा इंशाल्लाह एडवांस लेवल्स पे ले जाएगी, बेसिक स्टार्ट करते हुए। और जिस तरह की ये इसकी इम्पोर्टेंस जो है इट्स वेरी मच कि आपको खुद भी पता है, इसी वजह से आप यहाँ मौजूद हैं कि ट्रेनिंग जितनी ज़रूरी होती है हर चीज़ के लिए, विदाउट ट्रेनिंग देयर इज़ नथिंग। तो दो चीज़ें बहुत इंपॉर्टेंट, जो सम ऑफ द मोस्ट इंपॉर्टेंट थिंग्स होती हैं उसमें से दो चीज़ें बहुत इंपॉर्टेंट होती हैं, कॉस्ट ऑफ डूइंग इट एंड ईज ऑफ डूइंग इट। आई थिंक हम अभी बैठे बैठे तो यही डिस्कस हो रहा था और बेसिक बात तो यही है कि कॉस्ट ऑफ डूइंग इट एंड ईज ऑफ डूइंग इट। तो जिस तरह आपके पास अगर इमरजेंसी में पेशेंट्स आते हैं तो उसके लिए भी यही ज़रूरी है कि उसकी कॉस्ट ऑफ डूइंग दैट प्रोसीजर या क्या रिक्वायरमेंट है, उसको किस तरीके से उसकी लाइफ बचाई जा सकती है या किस तरीके से और कितना आसानी से बचाई जा सकती है। तो ये दोनों फैक्टर्स जब तक आप अच्छे ट्रेंड होंगे, आपके पास अच्छे इक्विपमेंट्स होंगे, आप वेल डेवलप्ड होंगे, वेल इक्विप्ड होंगे, वेल नॉलेज होंगे, तो फिर ही मुमकिन हो सकता है। तो आई थिंक पाकिस्तान में इस चीज़ की बहुत बहुत ज़्यादा एक बड़ी रिक्वायरमेट है। अभी हम डिस्कस भी कर रहे थे कि कितनी गैप है यहाँ पर, कितने ज़्यादा हमें मज़ीद ऐसे डॉक्टर्स चाहिए जो इमरजेंसी में सारा कुछ, और इट्स लाइक ऑल राउंडर, मतलब ये आप हर चीज़ देखें। आप अल्ट्रासाउंड मशीन जहाँ पे लाए हुए डॉक्टर साहब और आपको ट्रेन करें, तो आई थिंक इट्स अ ग्रेट अपॉर्चुनिटी फॉर ऑल ऑफ अस बीइंग अ पाकिस्तानी एज अ नेशन। कि यहाँ कराची में भी कर रहे हैं और उम्मीद है कि ये नेक्स्ट वीक में लाहौर भी शायद जा रहे हैं और वहाँ पे भी करेंगे। तो आई एम रियली आई गिव सल्यूट टू यू और थैंक यू सर कि आपने फैमिली को टाइम देने की बजाय यहाँ पे दिए। दैट्स द कॉस्ट जो ये पे कर रहे हैं कि, लेकिन स्टिल आई बिलीव कि जो इसका रिजल्ट है वो बहुत 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 ज़्यादा इससे बड़े नतीजे निकलेंगे। और पेशेंट जो है, जो अल्टीमेट हर एक डॉक्टर का एक बेसिक काम है, बेसिक फ़र्ज़ है कि हम पेशेंट को जो है वो जितने आराम से उसको जितने तरीके के साथ सही कर सकें, जितनी बेहतरी के साथ, जितनी इजी उसको फील हो। तो आई थिंक इससे ज़्यादा बेहतर कोई और चीज़ नहीं होगी कि आप इमरजेंसी में फर्स्ट एड के अंदर ही फर्स्ट देखते हुए ही हर चीज़ मुहैया कर दें। मेरे अपनी एग्जांपल है, मेरे फादर को प्रॉब्लम हुई हार्ट की, हम लोग हॉस्पिटल गए। आगा खान वॉज द बेस्ट एट दैट टाइम वी बिलीव। और वहाँ जाके हम, रात का टाइम था 2 बजे का, देयर वाज नो कोई कंसल्टेंट डॉक्टर नहीं था, कार्डियोलॉजिस्ट नहीं। तो बस वो जूनियर डॉक्टर थे बेचारे, वो आके एक ने डाटा लिया, दूसरे ने डाटा लिया, तीसरे ने डाटा लिया, बट नथिंग वाज स्टार्टिंग। तो कुछ कर नहीं रहे थे। तो आई वाज वरीड कि जी कुछ स्टार्ट तो करें। तो 1 घंटे के अंदर वो जो एंजियोग्राफी की उनको जो प्रॉब्लम हुई हुई थी एंजाइना की, वो ऐसे थोड़ा नेचुरली सही हो गया। तो रीसेट के लिए बस वापस चलते हैं, मुझे यहाँ से वापस चलना है। तो वो कहेंगे नहीं नहीं आप बैठें, आप रुकें, लेकिन कर कुछ नहीं सकते थे डॉक्टर्स। वो जो जिस तरह डेटा ले रहे थे 3 से 4 महीने का, जी हम रिकॉर्डिंग करके रख लेते हैं, आपको बार बार आना पड़ रहा है तो हम आपको बार बार रिकॉर्डिंग सुना देंगे कि जी ये हुआ, ये हुआ, ये हुआ। बट देयर वाज नो, उस वक्त भी मुझे फील हुआ कि ये तो आज से 20 साल पहले की मैं बात कर रहा हूँ। तो आज से 20 साल पहले यहाँ पे ये सिचुएशन थी और आज भी मुझे लगता है कि अभी भी यही सिचुएशन है। और आज तक हम अगर किसी को रिकमेंड करते हैं तो कहते हैं कि NSCVD ले जाओ, एटलीस्ट वहाँ पे डॉक्टर 24 आवर फॉरन तौर पे कुछ ना कुछ लगा के आपको स्टार्ट कर देंगे। ECG वगैरह करना शुरू हो जाते हैं, फॉरन स्टार्ट करते हैं। तो आई थिंक जो ये अगर ट्रेनिंग देते हैं और आप सबको ट्रेनिंग मिलती है, तो जिस जिस इंस्टीट्यूट में, जिस जिस इदारे में आप लोग बैठे होंगे, जहाँ जहाँ आप लोग हॉस्पिटल्स में, क्लिनिक्स में होंगे, एटलीस्ट लोगों के लिए वहाँ पे फौरी तौर पे आसानी होगी कि एटलीस्ट उनको पता है कि जी इमरजेंसी में हम जाते हैं तो यू पीपल कैन रियली सपोर्ट देम, यू पीपल कैन रियली हेल्प देम कि किस तरीके से क्योर करना है। एंड सल्यूट टू ऑल ऑफ यू। और इंशाल्लाह उम्मीद करता हूँ कि ये जो प्रोग्राम है उससे आप लोग सीख के जाएंगे और पूरे मुल्क को फ़ायदा होगा। थैंक यू सो मच। थैंक यू।
Again, thank you, Mr. After Iqbal, for your kind words and your intentions. बहुत कम लोग होते हैं जो मुश्किल वक्त में, मुश्किल काम में स्टेप अप करते हैं. So thank you very much. Thank you. We'll continue on. Please lights soften. So next is abdominal artery aneurysm. We're going to talk about that. Objective of this very quick presentation is to know what the proposition is. Okay. Look at the proximal, mid, and distal aorta. Okay. Look for the longitudinal view. Look for sacral artery aneurysm, leaking aneurysm, and dissecting aneurysms. So knowing your numbers. If it's greater than 3 centimeter, it's abnormal. Okay? If you can see the lumbar vertebra, and if it's bigger than the lumbar vertebra, equal to the lumbar vertebra, it's big. Okay? It's most likely above 4 centimeter. If somebody is coming with hypertension and it's greater than 5 centimeter, it's ruptured unless proven otherwise. Okay? So these are very small things. यानी आपको अगर मेजरमेंट नहीं भी करनी आती है, आपने देखा ये वर्टिबल बॉडी से बड़ा है, लंबर वर्टिबल से बड़ा है, या उसके साइज का है, इट्स मोस्ट लाइकली एनलार्ज. एनलार्ज डजंट मीन कि वो लीक कर रहा है, मे बी नॉट, बट इट्स एबनॉर्मल. ओके, so what's the proper position? Pointer again towards the patient's right or towards the patient's head. ठीक है? And against the curvilinear probe, the same probe that I showed you earlier is this one. And this is what you need to see. You need to see the vertebral body, you need to see the aorta, and you need to see the IVC. IVC is going to be collapsible, aorta is going to be pulsatile, and this is the lumbar vertebra. Okay? Is it clear enough? जब हम लोग ह्यूमन बॉडी पे भी दिखाएंगे ना आप लोगों को, it's going to be very clear. So once you see it, you will not be able to miss it. Okay? Inshallah. This is the proximal transverse view. Cross section ले रहे हैं आप aorta का. ठीक है? This is called the Siegel sign. This is the celiac trunk that's split into, on the right side कौन सी artery जाती है? Hepatic, yes. And the left side? Splenic. Celiac trunk से निकलते हैं. This is celiac trunk, this is the beginning of the aorta. This is the aorta, this is the vertebra over here. Okay?
This reminds me of a very interesting case. Keep this picture like this. And
Siegel sign.
actually,
pause नहीं हो सकती.
we managed to pick up a very life-threatening, important diagnosis. So if you see this celiac trunk, on the right side is the right hepatic artery. On the right side, right hepatic artery. On the left side, the superior mesenteric artery, isn't it? And I had a patient with the just kind of epigastric pain, not much signs, no rigidity, nothing. We put the probe and we found out a thrombus in the superior mesenteric artery. You can believe it. This patient would have gone into small bowel ischemia. Luckily, she did have ischemia because the thrombus was still not completely occluding that. And when we put the Doppler start, so as soon as you see a thrombus, you will start the Doppler and you will see whether the flow is going on or not. So this is a miracle, isn't it? It's just you put the probe and you can pick up a thrombus in the superior mesenteric artery, you actually save that person. And that was through the intervention radiologist, it was removed like that. And the patient survived. So I hope you will learn this today. We'll show you how the thrombus looks like. Everybody any slides of thrombus?
No.
Maybe, okay.
We echo वाली can देख thrombus.
We can see it.
Again, ये thrombus पकड़ना मैं नहीं पकड़ सकता, ये बात वही पकड़ सकता है.
You can do it.
But you can do it. If you find it, maybe you'll find it.
You can do it, it's not a problem.
ठीक है, next. So this is the proximal aorta, and again, knowing your anatomy is so important. If you know your anatomy right, you'll know your sternal anatomy. And I can guarantee you, most of the doctors, when they reach the registrar level, their anatomy in the UK, the UK graduate is not as good as yours. ये मैं आपको guarantee दे रहा हूँ. क्योंकि हम लोग की critical thinking थोड़ी सी weak है, लेकिन हम लोग का रट्टा बहुत strong है. ठीक है? तो हमें पता है कि यार superior mesenteric है या celiac trunk है, पहले celiac trunk आएगी, फिर superior mesenteric आएगी, celiac trunk से right पे hepatic होगी, left पे splenic होगी. ठीक है? Next.
This reminds me another case.
This
was a
वो आप ये लोग आपको केस बता रहे हैं ना, इससे आपको याद रहेगा.
And we had a female, 36 weeks pregnant, advanced pregnancy. And again she came with abdominal, slight epigastric pain. And normally people send them as reflux, isn't it? Right, reflux and all. Again, we have a habit to put the probe in. We put the probe that side. And on the previous case I said the thrombus was in the right mesenteric, but superior mesenteric artery, but that one was a thrombus in the hepatic one. We picked up the hepatic vein thrombosis when we were doing. So basically, pregnancy is a hypercoagulable state, and you know that classical butt carrier syndrome. And you pick up so many portal vein thrombosis. Once you know how to look at the thrombus, you can easily pick up. The aorta should look black, the vessels should look black, all the blood supplies should look black. But if you see a hyperdense stuff in it, that's a thrombus, and you can pick it up. And imagine you can, that lady, she just required anticoagulation, really, heparin. No one would have given her. They would have just given her, pantoprazole or Rifac. So what would have happened? In advanced pregnancy, she would have gone into acute fulminant hepatic failure, and then she would have died. So, such a simple, small stuff. You will save so many lives with ultrasound that you can't believe. This skill is going to change your whole perspective of management. Thank you.
Okay, thank you.
Thank you, sir.
So this is the mid-transverse view. हमने आप superior view देखी थी, superior transverse. This is the mid-transverse view. See, and again, Ashfaq bhai भी इससे agree करेंगे कि most of the residents, trainees don't know how to pick up a triple A over there. They will consider that this is normal 2 centimeter size aorta. Well, actually, you're missing the big picture, which is screaming at you that, hey, mister, look at me, I'm this large, 7 centimeters. Okay? So this is the false lumen inside. It's expanded, there's blood and hematoma around it. Okay? This is a mid-transverse view, very easy to pick on the mid-transverse view. I will also explain how the position of the patient should be to get the best optimal images. Okay?
And that's how the thrombus looks. If you see
Yes.
within the middle, that's how a thrombus looks like.
Something like this.
It will be bigger one.
Yeah.
And as you said, the false lumens. What happened when there's a thrombus there? The natural history of thrombus is either there will be a recanalization, all pathophysiology. There will be a new blood channel formed, which is a false lumen, or the thrombus can rupture, or it can resolute, or it can stay there forever. So again, this reminds me another case, which was a very interesting case. We had a patient who came with basically a tingling numbness and mainly the pain in the right leg, and was referred to us as a sciatica. And patient was that that non-weight bearing, unable to walk, he's got a pain going down to the leg, possible sciatica. Again, we had an habit. So whatever patient comes with, if you are learning, if you want to sign up your logbook, you will do scans on everyone. We put the probe on that patient. There was an aorta, with this aorta, similar one, there was a thrombus, and actually he had a thromboembolism. He had an acute limb ischemia. It was not a sciatica. And then again, that patient went for vascular and actually survived complete recovery. So this is another. I think I'm just interrupting you.
Go ahead. The point is
so many interesting stories.
The point is, I'm learning, and thank you very much. And as long as we can learn, as long as I can learn from you, feel free to interrupt. यहाँ पे मैं कोई बॉस नहीं हूँ या कोई मेरी फाउंटेन ऑफ नॉलेज है जो कि अनलिमिटेड है, वो ऐसा नहीं है. आई गॉट लिमिटेड नॉलेज, आई एम जस्ट इम्पार्टिंग इट. एंड अगर शफाक भाई इसमें ऐड करते हैं, आई एम द हैप्पीएस्ट पर्सन, तो गो फॉर इट.
मुझे फॉल्स लिमिट की वजह से ना याद आया कि इसको फॉल्स लिमिट क्यों कहते हैं, ताकि बच्चों को.
Good, thank you. Yeah, we continue on. Mid transfers. Next is distal transfers, very important. लोग समझते हैं कि एओर्टा जो है ना बस मिड ट्रांसवर्स तक ही है. You have to go all the way distally to the common iliacs. Can you see the common iliacs here? Can you see the vertebra? Yes? Identify the vertebra. Above it is the aorta. As you go distally, it will split into two. Okay? And this is the point, if you don't see an aneurysm, you can safely say that there is no obvious aneurysm. Okay? Simple. So this is the distal ones. This is how it looks like. Now we look at the longitudinal view. This is the proximal end. This is the distal end. Now how will you know that which is proximal and which is distal? If you look at the anatomy, the aorta arises from the posterior area of the diaphragm. This is posterior, this is anterior, this is proximal, this is distal. It will always curve down. And as you go up, it will, as you go down distally, it will go slightly up. Okay. It also depends how the lumbar curvature of the patient is, whether the patient is hunched forward or the patient is in an extended position supine. Okay. What is this? That's good. So this is the aorta. What's this? No. So in this view, think about it. Think before you speak. Does the IVC lie anterior to the aorta, posterior, or on the right side? On the right side. So what arises anterior to the aorta? A big. No. Superior mesenteric. Superior mesenteric artery. So Ashfaq bhai बताया था ना, depict the thrombus. This is how they pick it up. Superior mesenteric artery, anterior to the aorta. You pulse the pulse wave on it, it will be pulsatile. You know it's not a vein. Okay? आवाज आती है, whoosh, 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 like this. So this is superior mesenteric. Longitudinal view की importance थोड़ी बता रहा था. Okay? And once you get the images right, जैसे आप pause करते हैं, आप pause करके उसको measurements ले लेते हैं आपकी. For example, in this view, आपने इस image को still किया, freeze किया, image ली, मैं तो कभी कभार phone से भी ले लेता हूँ patient के permission से, ठीक है? And then you measure the distance outside to the outside, not inner to inner. It's the outside diameter to the outside diameter. ये FRCM का question है, ठीक है? How will you measure it from the outer to the outer? अगर पूरे ट्रिपल ए में अगर कोई चीज़ आपको सीखनी है ना, एटलीस्ट कम से कम ये सीखिए.
So can you repeat?
The outer diameter, you have to measure from the outer diameter to the outer diameter. Outer diameter, not the inner. ये outer है, ये inner है. Okay? Outer diameter to the outer diameter. This is the right way to measure it. Okay? क्योंकि अक्सर calcified aorta होती है. Thickening of calcification इतनी बढ़ चुकी होती है, आप काउंट नहीं करेंगे तो you're not measuring the true width to diameter. Okay? Longitudinal आपने देख ली, ठीक है? And any questions on that? Again, probe pointed towards the head and the rest towards the feet. Saccular aneurysm. This is how it looks like. In fact, in my last shift, just in the UK, I picked up saccular aneurysm. I'll show you on my phone. So this is how it looks like. You know what view is this? Transverse or longitudinal? Yes, transverse view. ठीक है? Bulb upon bulb. Okay? Bulging upon bulging. Saccular aneurysm. Okay? Next. Again, on the longitudinal view, how will this saccular aneurysm look like? See? A man with a belly. ठीक है? Literally a belly type की निकली है. देख रहे हैं? This is how it will look like. आपने normal longitudinal दिखाई थी मैंने आपको? ये. See the difference? So basically, when you see enough normals, as soon as you pick an abnormal, you're not going to diagnose the saccular concept, but you will know that's an enlarged aorta. Okay? And the context, clinical context, you will diagnose whether it's leaking, ruptured, किस पेन के साथ आया, तभी तो आपने इससे पहले स्कैन किया है. ठीक है? Longitudinal cross section, longitudinal saccular aneurysm, leaking aneurysm. Can anyone identify where the leak is? Raise your hand. Where is it? Look at this. Leaking aneurysm. Isn't it beautiful? मैं तो बड़ा excited हो रहा था देख के. Not in a bad way, but like यार इसकी life save हो रही है. Okay? It just completely transforms my day. मुझे full energy आ जाती है, मुझे कोई कॉफी की जरूरत नहीं होती, मुझे खाने पीने की जरूरत नहीं होती. I just get energetic. ठीक है? जैसे अशफाक भाई full time energetic होते हैं ना, मैं थोड़े देर वक्त के लिए हो जाता हूँ.
You see there is a big thrombus there. Can you see
Yes.
that?
This one? This one?
These are the thrombus.
That's it. Okay?
Yes, sir.
Dissecting aneurysm. अशफाक भाई बात कर रहे थे dissecting aneurysm हमने पिक किया था. Can anyone identify where the dissection is? Yes.
Right.
Yeah. dissecting of the walls basically. It splits into 2 or 3. Okay? Okay, boss?
Yes.
What's the reason for you want to talk?
Dissection, we have picked so many dissections.
Yes.
I think now we are there is a focus scan done for the dissections in many hospitals. I still remember in North Middlesex, where
Kata is sorry,
there is a very high number of Turkish population there. And I don't know, somehow, they are very high risk of dissection. At least once a week you get someone there. And they have made a protocol for a dissection. So you can imagine the department has to make a protocol for dissection. So actually you can do the
transverse.
Yeah.
Suprasternal.
Suprasternal, and you can actually pick up dissection from.
Classic.
But that's an advanced level. You won't be going at that level at this stage. But next year, inshallah, you will be.
Yeah, after leaving from today's teaching, don't be surprised if you find a pathology and save a life the very next day. ठीक है? I would not be surprised कि अगर आपने किसी की life कल save की हो, जो आप आज सीख रहे हैं. It can very well happen. ठीक है? So this is dissecting aneurysm. Any questions? Very simple, smart. Any questions at all? कुछ तो सवाल पूछो यार. फाउंटेन ऑफ नॉलेज बैठे हुए हैं हमारे पास. मैं तो उनको कहते हैं ना, जितना पी सकता था इनसे ड्यूरिंग फ्लाइट मैंने पिया इनको. बहुत क्लिनिकल और नॉन क्लिनिकल बातों में, और बहुत कुछ सीखा. दिस वाज प्रोबब्ली वन ऑफ द बेस्ट जर्नीज ऑफ माय लाइफ जो मैंने सीखी. सीक्रेट एडमिनिस्ट्रेशन हमारे सर ने खाया. मूविंग लाइब्रेरी. गूगल. Don't be surprised if he becomes the next Adib Rizvi. My mother says that. ये तो अदीब रिजवी वाला काम कर रहा है. मैंने कहा सर, probably ma'am, me, probably more than that. Okay, so this is finished. This is my contacts, and we're going to go to the next slide. Next presentation is. ये कैनवा ने मेरी लाइफ बहुत आसान कर दी है. Not sponsored. It's not sponsored. Now we're going to go for echo. Okay. Internet चल रहा है? यूके में कहते हैं don't share your screen, mobile screen on the presentations. So they think I'm very brave. I think this is it, yes. So now we can learn a bit more detail on echoes. Echo in life support. This is very specific target that we'll try to learn today. Okay. Thank you, Isma, for helping us out with Ashwat bhai. Otherwise, bhai ki मेहनत चली जाती. Okay, so we can start with echo in life support. Any case that you guys know that you have saved a life, or you've seen somebody saving life with an echo? I was just having a chat with one of my cousins who works in NICVD. She just qualified for FCPS, and I've realized the things that they are doing as a cardiologist, we as EM physicians are doing for bedside echo, or probably more than that. So ये जो चीज़ें ये यहाँ पे कार्डियोलॉजिस्ट कर रहा होता है, जो कि वहाँ पे EM फिजिशियन कर रहा है. आप लोग इंशाल्लाह करेंगे, ठीक है? So quite a few views, I think 5 views that we have to learn. Subcostal view, ठीक है? अब Remember the fast scan, the probe position was either patient's towards patient's right or towards the head. When you're using a cardiac probe, it's a slim pen-like probe. Everything is opposite. Okay? We'll learn about the pointer later on. If there's one thing I don't want you to get confused today about the pointer position. If you know your anatomy, the pointer position does not matter. Okay? For EM physicians, for a radiographer, for a sonologist, for a cardiologist, it matters a lot, but we're not going to fuss about it. Okay? Our aim is to look at few little things, and it does not matter where the pointer is. But I've shown where the pointer is in the images. Pointer is towards patient's left in the subcostal view when you're using the cardiac probe. Okay? Not with the curvilinear probe, with the cardiac probe. Okay? And for echoes, we always use the cardiac probe. Subcostal view, how will this look like? If you take a cross section of where the light is going, again, you look at the liver. Here's our clear views, I think. Last one image set. Right ventricle, right atrium. Again, you look at this. Right ventricle, right atrium, right side first, left ventricle, left atrium. Subcostal views. Okay? Clear? Normally आप इसी तरह की images देखेंगे आप जब echo करेंगे ना तो this is roughly इतनी clear होती है images, so you can't go wrong. Subcostal view, again, remember this one? The fluid in the pericardial region? This is all you need to pick. Simple, कितना simple है? But you will save a life once you get a diagnosis. You suspect a diagnosis, you can confirm the diagnosis, and then you try to treat it. Is that clear? Again, subcostal view, a bit much more clear, dark colored pericardial effusion. And the heart is clearly struggling. There is no equal movements of all the ventricles towards this center point. एक side asymmetry है, this side is not moving. I can't get these views, but there may be fluid around here as well. So definitely you see some fluid here. Okay, and if you can see it anteriorly, on the anterior of the heart, there is bound to be some fluid here as well. Okay, because the dependent part has got more fluid, naturally. Then we come to the parasternal long axis view, we discussed that. The pointer will be towards patient's right shoulder. Okay, and this is what you will see. You go cut through the heart, and at least you know where the pointer is, the parasternal long axis view. Yeah? And this is what you will see. Right ventricle, left ventricle, AV valve. I've always explained this in the previous slides. Okay? And this is what you will see. Again, sorry. This is what you will see. Okay? Again, you know what to look for. You're looking for pericardial effusion. You're looking for the right ventricle. Is it bigger than the left one? That means there's some kind of increased pressure on the right side. It may be a thrombus, it may be a PE, and anything can lead to this. Okay? But these very much look like a normal view to me. And you see equal right ventricle, aortic valve, and left atrium. Okay? Next. Again, parasternal long axis view, a very clear view here. Looks like normal parasternal long axis view, right ventricle, left ventricle, aortic outlet, left atrium. Okay? अब ये दिमाग में embed हो रहा होगा आप लोगों के. It's not that difficult.
And imagine if you're doing this view and if you see a clot in the left atrium, how happy you will be. Because that clot can actually cause a stroke. And you can actually pick it up by just doing that side test. And once you start doing it, you will be picking it up.
Yes.
So many, which is very, you will see them.
There's an English saying, you stay with the barber long enough and you'll get a haircut. ठीक है? So अगर आप एको करते रहेंगे, अल्ट्रासाउंड से प्रैक्टिस करते रहेंगे, you'll pick up pathologies. And I'll be very happy आप मुझसे शेयर करें, मैं तो बस it will just make my day. Okay? PLAX view again. There's things inside. I'll repeat it for a sec. Again, some slide. And, oh, I think it's good. Hold on. I think there was a pathology in this one. No. Sorry, I've got a thrombus view as well, which I'll show you later on. Yes, there is one. Yeah, there is one. So this is the personal short access view. जब मैं शुरू में एको करना शुरू किया था ना, मैंने कहा यार ये तो सबसे मजे की व्यू है, सबसे आसान है, सब कुछ नजर आ रहा है इसके अंदर, रेस्ट्रिक्टेड, बट ये सबसे मुश्किल होती है करना. Personal short access view, in which the pointer is patient towards the patient's left shoulder. Okay? लिखने की कोई जरूरत नहीं है बेटा, लिखने की कोई जरूरत नहीं है, जस्ट लिसन. अगर याद हो जाता है ठीक है, नहीं याद होता तो लिख भी लोगे, याद नहीं रहेगा. ठीक है? डॉट्स फिल करनी, वो यहाँ पे भी करेंगे तो हो जाएगा.
ये जो हम पॉइंटर कर रहे हैं, तो ये इसमें अपर पार्ट का व्यू आएगा और नीचे वाला जो
हाँ, सो गुड क्वेश्चन. आपका ये प्रोब लिटरली कार्डियक प्रोब इस टाइप का होता है. ठीक है? तुम्हारा दिल, and this is what you're going to see. So suppose this is the cardiac probe. Okay? आपने second, third, fourth के बीच में roughly देखा. ठीक है? Pointer is towards the right shoulder for parasternal long axis. ठीक है? इसको आपने rotate कर दिया longitudinal view पे. Pointer towards the left shoulder. अब sorry आपका नाम क्या है? डॉक्टर सिद्दीक.
एक तो आएगी, अब सामने वाली की आएगी, नीचे वाली की नहीं आएगी.
अब मैं बताता हूँ. ठीक है? अब आपको क्या करना है? You know this is like a torch. ठीक है? You wave it up and down. I will show you how to do this. You wave it up and down, and you will fan across the whole length of the ventricle from the apex all the way to the walls. ठीक है? तो आपको पूरी view हार्ट की नजर आ सकती है इस व्यू के अंदर. Okay? But slightly challenging at times to get this view. ठीक है? But once you find it, आपने ऊपर से लेके नीचे तक हार्ट को उसके एक्सिस पे स्कैन करना है.
नीचे वाला हिस्सा वो कट ऑफ हो गया,
नीचे वाला भी नजर आएगा सर. नहीं, आपको पूरा नजर आएगा. मैं आपको दिखाऊंगा करके. अगर इस फोर्स से होते हैं मैं आपको दिखाऊंगा. हाँ, ये इसमें नीचे वाला भी इसमें नजर नहीं आ रहा, एपेक्स चला गया इसमें. ठीक है? लेकिन अगर आप ये तो आपने सीधा रखा हुआ है तो आपको एपेक्स नहीं नजर आएगा. ठीक है? फिर आपने टुवर्ड्स द एपेक्स मूव करना है प्रोब को, आपको एपेक्स भी नजर आएगा. आपको रीजनल वॉर्ड मोशन एब्नॉर्मैलिटी इस व्यू में पिक कर सकते हैं आप. ठीक है? और इसका फिर आप पूरा ऊपर तक ले जाएंगे इसको. ठीक है? सो वंस यू फाइंड दिस व्यू, कुछ नहीं करना, सिर्फ हल्का हल्का टिल्ट करना है एंड यू कैन आइडेंटिफाई कि आपके एपेक्स मिल रहा है, ये सेंटर मिल रहा है, ये प्रॉक्सिमल ऑफ द वेंट्रिकल मिल रहा है. ठीक है? बहुत सटल मूवमेंट्स होती हैं, कोई एक्स्ट्रा थैंक यू. बहुत सटल मूवमेंट्स होती हैं, उससे आपको सब चीज़ नजर आ जाती है. बहुत बड़ी मूवमेंट नहीं करनी है, आप पेट में पहुंच जाएंगे उसके. ठीक है? और जहाँ एक रजिस्टर था, नाम नहीं लूंगा, वो हार्ट को स्कैन करते करते सब क्लेविन तक पहुंच गया. दिस इज हाउ बैड दे कैन बी. विद ड्यू रिस्पेक्ट, दे माइट बी गुड इन अदर थिंग्स एंड आई माइट बी बैड इन अदर थिंग्स. लेकिन यार कुछ चीज़ें बहुत बेसिक होती हैं, आपको आनी चाहिए. ठीक है? और आज आप लोग सीख लोगे वो चीज़ें. ठीक है? फिर आपको जस्ट प्रैक्टिस करनी है. और रियली गुड क्वेश्चन. यहाँ पे हमारे पास किस कैंडिडेट के पास अल्ट्रासाउंड को मशीन टच करने का एक्सेस है, जो सिर्फ छू सकता है, ये छू भी सकता है. यानी उसे देखिए कि इसके डिपार्टमेंट में इसके कौन कितने लोग हैं. और भी तो लोग हैं ना, बहुत सारे लोग थे, हम कहते हैं हमारे पास भी अल्ट्रासाउंड मशीन है. हॉस्पिटल में किस के है? सबके है ना. सबके हॉस्पिटल में आपका कोई एक ऑफ द नेक्स्ट जो डे मिलता है ना, उसमें आप जाएं और उनसे बोलें कि आप जो कर रहे हैं ना मुझे सिर्फ देखने हैं. जब आप पूरे दिन बैठेंगी ना, तो आपका नेक्स्ट ऑफ डे जो होगा ना, उसमें जाना, वो आपको पकड़ने भी देगा प्रोब. आप खुद ही करना और सिर्फ दबा के प्रोब से प्रैक्टिस करो. जस्ट 1 डे, 12 घंटे लगा के. जितना आज आप लर्न कर रहे हो ना, इससे ज़्यादा सीख जाओगे आप.
इसका सबसे आसान तरीका ये है कि जो भी आपका सोनोलॉजिस्ट है, सोनोग्राफर है, उसके लिए आप यू हैव बिल्ड अ गुड रिलेशनशिप विद देम एंड दे आर रियली वेरी गुड एट टीचिंग। प्रॉब्लम ये है कि उन लोगों को आप कंसिडर ही नहीं करते ना। कितनी दफ़ा आप अपने सोनोलॉजिस्ट से मिलते ही नहीं है। वो बहुत टीच करेंगे, उनको आप जाके कहेंगे आई एम गोइंग टू सिट हियर एंड आई एम गोइंग टू वॉच यू, क्या वो आपको मना करेंगे? नहीं मना करेंगे। और फिर आपका जब रिलेशनशिप बिल्ड हो जाएगा, कैन आई टच द प्रोब, दे विल लेट यू डू। कैन आई टेक वन प्रिंट आउट, आपका एक स्कैन हो गया, ठीक है। कभी आप उनके लिए कोई गिफ्ट ले जाएं, कोई ऐसी चीज़ ले जाएं, तो दे विल बी फील ऑनर्ड। तो खाड़ी या बरीजे की कोई भी दे लाइक।
बेसिकली हर इंसान को जिसको तुमसे कम भी आता है उसको अपना उस्ताद बना लो, क्योंकि ज़रूरी नहीं जो उसको कम आता है डजंट मीन कि तुम्हें वो चीज़ आती हो। क्या पता उसको पास बहुत कम नॉलेज है लेकिन वो नॉलेज नहीं हो जो वो नॉलेज तुम्हारे पास नहीं हो जो उसके पास है। तो मैं तो हर इंसान को अपना उस्ताद बना रहता हूँ। आप भी मेरे उस्ताद हैं। कुछ दिन बाद आप मुझे सिखा रहे होंगे कि यार डॉक्टर अली मैंने ये देखा, मैं कहा यार ये तो मैंने नहीं देखा था। तो दिस इज द बेस्ट फीलिंग। मैं अपने उस्ताद बढ़ाता हूँ, ठीक है। दिस इज हाउ आई लर्न। आई टीच अदर पीपल एंड देन दे टीच मी, ठीक है। एक्सेप्ट अशफाक भाई उनसे सिर्फ सीखता हूँ। ठीक है बॉस। तो पैरास्टल शॉर्ट एक्सिस व्यू बहुत अच्छी व्यू है। अगर इफ यू कैन गेट इट यू सी अ लॉट ऑफ थिंग्स इन दैट। Getting on to the details of the parasternal short axis view. Normally, right ventricle should be D-shaped. This is the O-shape. If this has become D-shaped, that means the right ventricular pressure has increased. ठीक है। दूसरी बात, anterior wall, posterior wall, lateral walls, इसमें आप देख सकते हैं। And as you scan the probe, जैसे मैंने इनके ऊपर करके दिखाया था, आप पूरा ventricle देख सकते हैं। और जहाँ पे भी regional wall motion abnormality होगी, इसमें पिक हो जाएगी आपकी। हर व्यू से पिक हो सकती है लेकिन इसमें भी आराम से पिक हो सकती है, ठीक है।
इसको एक चीज मुझे याद आ गई, D sign. Basically, if you see, this is the reverse of the D, isn't it?
Yes.
Normally, left ventricle is large, right is small. So you see the reverse of D. If there is a massive pulmonary embolism, this D is shifted towards that side, and in the left ventricle you will see the D sign. You will get the MCQs in your exam where you have to pick that up. They show you this, this picture, and they will ask you what view is this. And in some SAQs they can ask you, is this adequate? Because if you don't see the right ventricle full, they usually bring you the inadequate views, and then you say this is inadequate views.
Yes.
So don't comment, this is parasternal short axis, this is this. You just say, you can't see the right ventricle wall, this is inadequate view, and then you dismiss that. So there's so many learning points here.
Thank you. ये FRK में फाइनल में क्वेश्चन भी आया था इसके ऊपर। They showed the images and they asked, and quite often FRK लेवल पे they will give inadequate views. आपको यही नहीं पता कि adequate views में कौन सी चीज़ें include होनी है, then you miss it.
And in the OSCE, they bring you a SHO who will bring the images of this, and he will say that, I have done this, can you sign me off? आज आप मुझे साइन ऑफ कर दो, मेरा कल रोटेशन खत्म हो रहा है। और उसके आप जब व्यूज देखेंगे तो उसने inadequate views लिए होंगे, and then you have to teach that this is inadequate, why they are inadequate, I can't sign you off. So this is all your exam is about.
और ये ऐसी चीज़ें जो आपको एंड ऑफ द एग्जाम आप नहीं सीख सकते, ये आप ग्रेजुअली सीखते हैं। दिस इज आर्ट, ठीक है ना। आप कहें कि भाई मुझे सर्जरी सिखा दो, एक दिन में नहीं सीख सकते आप। सो स्लो, दिस इज आल्सो हैंड स्किल। यू विल लर्न, यू विल श्योरली लर्न स्लोली, बट यू विल लर्न। ओके, नेक्स्ट है अगेन पैरास्टर्नल शॉर्ट एक्सिस व्यू। एबनॉर्मलिटी पिक करें इसके अंदर क्या हो रहा है। राइट साइड देखें, बड़ी है छोटी है? लेफ्ट साइड छोटी है, प्लस आप एसिमेट्री ऑफ हाइपरट्रोफी नहीं है, एसिमेट्री ऑफ वॉल मूवमेंट है, ठीक है। नॉर्मली आप जब ये इमेज देखेंगे ना, एक सेकंड सॉरी, लास्ट वाली इमेज दिखाता हूँ। सो दिस होल सर्कुलर मूवमेंट शुड कम टुवर्ड्स द सेंटर पॉइंट, ठीक है, इक्वली। ऑल वॉल्स शुड मूव इक्वली टुवर्ड्स द सेंटर, ठीक है। बीच में फिंगर रखें प्रोब के, जब इमेज मिले आपको ठीक है, अगर everything is moving towards center, that's normal. This is how abnormal struggling heart looks like. ठीक है, एक तरफ की वॉल मूव हो रही है, एक तरफ की नहीं हो रही है, ये फ्लैट स्ट्रेट हो रही है, पूरी सर्कुलर नीचे कंप्लीट नहीं आ रही है. When you see long many, you will realize it. प्लस आपकी गट इंस्टिंक्ट बोल देती है कि यार ये ना नॉर्मल नहीं लग रही है, but you have to see normal to find that normal. Anyways, so this is again struggling heart. Right side is very enlarged, left side. Yes, there may be a thrombus actually somewhere here. Or is it a wall? We can't comment till you scan the whole length. Okay? अभी थॉमस वाली इमेज आपको दिखाता हूँ मैं. Past short axis. Sorry. Yes, apical four chamber view. ये भी मुझे थोड़ी मुश्किल लगती है, स्पेशली जो साइज ऑफ पेशेंट्स यूके में होते हैं बड़े बड़े. It becomes very difficult, especially in females. You have to go under the breast and then you have to look for the right place. And it becomes awkward for a male doctor to do it, but that's fine. We do it every day. But it becomes awkward. Pointer is face toward patients, left axilla. Okay? And this is what you see. Scan through the heart. You slice through the heart of the apex of the heart. Okay? And this is what you will see. Apical four chamber view. Right side, left side, okay? The first one will be the ventricles. ये ventricle नीचे होते हैं, आपका probe ये रहा, ठीक है? और right side, left side, okay? समझ आ रही है? Right side should be smaller, left side should be bigger. That's normal. इतना भी pick कर लिया ना आज के बाद, that's good enough. That's progress. Okay? Any questions?
ये जो पॉइंटर ऊपर से देख रहे हैं
जी सर.
पिक्चर आ रही है
जी.
इस वजह से उल्टा आ रही है.
बिल्कुल इस वजह से उल्टा आ रही है. ठीक है. मैं तो बस एक सिंपल रूल रखता हूँ. मैंने पॉइंटर रखा है जहाँ भी लिवर के साथ राइट साइड है, ठीक है, और उससे फिर रेस्ट ऑफ द एनाटॉमी आप कंस्ट्रक्ट करते हैं. ओके?
ओरिएंटेशन क्लियर हो जाए तो फिर
हाँ, देखो ओरिएंटेशन अक्सर लोगों की ना ओरिएंटेशन क्लियर नहीं होती है जिंदगी भर. उनको कितनी बार बता दो ना, पॉइंटर राइट पे रखना है, लेफ्ट पे रखना है. एको में पॉइंटर्स ऑपोजिट साइड पे होते हैं, कर्वी लीनियर में टुवर्ड्स द नॉर्मल साइड होता है. नहीं समझ आता क्योंकि उनको बेसिक एनाटॉमी नहीं पता. उनसे पूछो ना ये लिवर है या स्प्लीन है राइट साइड पे, अच्छा लिवर होगा राइट साइड पे. आपको तो ये सेकंड गेस सोचना ही नहीं चाहिए. Once you identify the liver, you go through the liver. Scan through the apex, apical में नहीं आती, लेकिन जो subcostal views में you go through the liver. Liver is your friend. Okay. Next. Can anybody identify the anatomy, so pathology? एक बंदा हाथ खड़ा करे. कौन राइट हो? कौन एग्री कर रहा है इससे? सोच लो. 1 2 3 4 5 6 ओए होए होए 7. सोच लो. आई श्योर? कितने कितने स्कैन किए इससे पहले? ये कैसे पिक कर लिया तुम लोगों ने? पैथोलॉजी थ्रोम्बस. ठीक है. आज तुम लोगों ने देख लिया ये बगैर स्कैन किए तुम लोगों ने आइडेंटिफाई कर लिया, क्योंकि तुम लोगों ने नॉर्मल इतनी ज़्यादा देखी है.
ब्लड तो आपको वो ब्लैक से आएगा, बाकी जो आपको थ्रोम्बस का
सॉलिड हो जाता है ना. सॉलिड. अशफाक भाई का सॉलिड. ठीक है बॉस.
You can send it to the interventional radiologist and they can take it out, put up anticoagulation and you save them from going stroke.
नहीं, इतनी सिंपल चीज. देखो तुमने कोई स्कैन कभी नहीं देखा, सिर्फ 4-5 इमेजेस आज देखी हैं तुम लोगों ने, एंड यू पिक्ड अप अ थ्रोम्बस. दिस इज हाउ इजी इट इज. दिस इज हाउ यू क्लोज यू आर टू सेविंग समबडीज लाइफ. एनीवेज, मूव फॉरवर्ड. वेल डन. और जिन जिन लोगों ने पहले पहले बोला था ना कि ये थ्रोम्बस है, सब सही थे. कॉन्फिडेंस लाओ अपने में. जो फर्स्ट थॉट है नहीं, इंसान की दिमाग जो होता है कभी रॉन्ग प्रोसेस नहीं करता. बहुत ही कम होता है कि रॉन्ग प्रोसेस. फर्स्ट थॉट इज ऑलवेज राइट. आ रही गट फीलिंग से जाओ.
ये थ्रोम्बस जो है राइट वेंट्रिकल में या लेफ्ट में?
Excellent.
कहाँ से आ रहा है?
कहाँ से आ रहे हैं?
आप कहाँ से आ रहे हैं?
Inferior vena cava. डिसलॉज हुआ और फिर ये चला जाएगा पी कॉज कर देगा. Yes.
When you see these clots in the right ventricle, you always see the clot in transition as well. कि
Oh,
और भी
yes.
तो नहीं आ रही. You put your probe on inferior vena cava, then femoral vein, then sometimes you will see 4 centimeter big clots. Even after that, there is another one, like a snake one. And then you have no option then to send them to the interventional radiologist and they can take it out. Or if patient is not for anticoagulation, you can plan inferior vena cava filter. And so just this one and the second one, if there is a clot in transition, you can do partial thrombolysis. Nowadays, in BARDs, they do the partial thrombolysis in patient with the clot in transition, which is a half dose of the normal thrombolysis.
So मेरा आज का learning point ये है अशफाक भाई से कि whenever you see a thrombus in a ventricle, vena cava will be लिखो. मैं excited होकर यहीं पे शायद छोड़ देता. But now this is my learning point. Okay. You stay along with learned people, you will learn more and more. Okay, next. IVC view. Pointed towards the head. Okay, and this is what you see to the slice of image. Pointer समझ गए? This is all through with cardiac probe. Sorry, ventricle fortune.
What will be the fate of this clot?
It will either get dissolved or dislodged. Patient will survive or die. IVC view. Let's move it forward. This is what you will see in the IVC view. Again, liver is my friend. Once you identify the liver, you are going through it. Yes. What do you see? Right atrium, inferior vena cava, liver. Okay? Heart is here towards the head. Okay, boss? Next.
इसकी प्रॉपर ओरिएंटेशन पूरी
बता देते हैं. यहाँ पे देखिए आपको क्या नजर आ रहा है. पहले इसको बता दें. सॉरी, ओरिएंटेशन. Again, head, feet, anterior, posterior. Simple. Okay? The probe pointer was towards the head. This is again inferior vena cava view. Again, that's the question for FRCAM that came in my exam. They showed an image of this with an M mode, motion mode. नीचे दिखाया था. Anyways, this is called the kissing sign. Okay? Excellent. Okay? You're going to the liver. You see the collapsing vein. If it's collapsing, it's probably underfilled. IVC. What's the normal diameter of the IVC? 1.5 to 2.5 centimeters. Okay? If it's not collapsing, it's overfilled. If it's collapsing, it's underfilled. Okay? Next. This is the M mode. This was the question that came in the exam. No. This is the M mode, and you're transecting through the IVC, and you see the collapsibility of the IVC. Okay, or that is variable with breathing. Okay, if you measure the highest distance and the smallest distance, it should be between 1.5 to 2.5. If it's not collapsing, it's dilated. It may be a thrombus. It may be overfilled. There was actually another case a couple of weeks ago. A patient came with what looks like sepsis, had sepsis, but had a dilated IVC. One of the registrar was scanning the patient. Because the patient was so underperfused, he was very drowsy. So what they did is they raised the, sorry? Sorry? They raised the foot and up and the head and down. And the IVC was dilated like anything. And they said, oh, don't give him fluid because he's overfilled. I said, you're scanning the IVC with the head and down, it's going to be filled anyway. And as soon as you put him in this flat position, ये basic common sense है ना, इसमें कोई book से तो नहीं पढ़ा, ठीक है? It was collapsing massively. So we gave him fluids, lots of fluids, and he became eventually well. But this little mistake of positioning the patient wrong, you got a dilated IVC, you're not giving fluids, the patient's going to die. Okay? So positioning is very important. Always consider the position of the patient. Okay? So this is again, the more you do it, ये पढ़ा नहीं था एकदम से मेरे दिमाग में आ गया, किसी के भी दिमाग में आ सकता है, आपके भी दिमाग में आ सकता है कि यार इसकी आईवीसी डायलेटेड क्यों है, क्योंकि सारा ब्लड पूल हुआ है हार्ट की तरफ. ओके, सो बी केयरफुल अबाउट दीज थिंग्स. वेंटिलेटेड पेशेंट्स के अंदर भी प्रेशर बढ़ा हुआ होता है. ओके, तो ये एम मोड जो है ना, इसके ऊपर भी हम लोग आएंगे अगर एक इस मशीन के अंदर होगा मोस्ट लाइकली इसके अंदर. ठीक है, आपको कोलैप्सिबिलिटी चेक करनी है. This is the IVC view. Okay. What do you think of any pathology in this one? Can you identify the IVC? Is it collapsing or not? No. Do you think it's overfilled? Possible? Yes. Do you think it's obstructed? Possible. Because of a thrombus somewhere possible? Okay? Or maybe it's positional. So you can't say on this image. You can't say on this image. You see the patient. So, difference between you and sonologist is you're seeing the patient. Okay? Sonologist will look at the image and diagnose. But you look at the patient, this is not the be all and all. It's not your end diagnosis. It's the addition to your clinical knowledge. Okay? Next. We're going to wrap up very soon. Thank you. All done. So, any questions on this?
Can you show the last slide and put the pointer?
Okay, hold on. Again, very important. Pointer is not important. Where do you think is the heart is? This side or this side?
Right side.
Right side.
Right side? Yes. Pointer इसका ऊपर है. देख रहे हो? ठीक है? Oh, sorry. This is the pointer. But look at the probe. कौन सा probe यूज हो रहा है इसके अंदर? Curvilinear. Pointer इसने मेरे ख्याल से foot end पे रखा है. This is your heart and this is the rest of the IVC. Okay? आपको ये देखें नजर आ रही है वाइब्रेशन हार्ट की. Okay? Contractility, sorry, not vibration. Again, you can't be sure because I'm not seeing the patient. I'm not a sonologist. I'm a clinician. I'll put the probe and then I'll see. Okay? But this is most likely the proximal end, this is the distal end, this is the hepatic vein. Okay? Important thing is, you should not miss that it's not collapsing. Okay? Any questions? Da-da-da. No questions? I'll get a question. Really say quick. Any questions? Questions?
ये IVC के दो अलग यूज हो रहा है. फुट एंड से था.
Pointer या foot end पे होगा या head end पे होगा. You have to identify where the heart is. Okay? आप pointer देखोगे आपको पता चल जाएगा कि heart किस तरफ है. ठीक है? Opposite end पे inferior cap vein cava होगी और liver पे आपकी hepatic vein जा रही होगी. Just have to identify. हाँ, वो opposite था. लेकिन again, you're not a sonologist. आपको identify करना है एक चीज. Is it dilated? Is it collapsing? Not, have you got a thrombus in it? That's all. You are not a sonologist. Don't train yourself. Don't train your mind to become a sonologist. Okay? Okay, last रह गई है. इसको भी जल्दी से करते हैं, फिर hands-on practice करते हैं. And this is my personal favorite, which is basically ultrasound guided access or blocks. Nerve blocks मुझे बहुत पसंद है, regional blocks मुझे बहुत पसंद है, ये बहुत मैं करता हूँ यहीं में. Some consultants don't like it because they think it's very risky, but I tell them I know my anatomy, I know what I'm doing. Thank you very much. Okay. I think 15 minutes लेंगे. I think it'll be 15 minutes. Okay, ultrasound guided vascular access. बहुत इंटरेस्टिंग है और इसमें हम पाकिस्तानी वी आर फार बेटर. हमारी हैंड आई कोऑर्डिनेशन और जो हमारी फाइन मोटर स्किल्स है ना, आपको अंदाज़ा नहीं है कितनी अच्छी है हमारी. ठीक है, सो दिस इज व्हाट वी गोना डू. ultrasound guided vascular access. अबे भाई चल जा. Okay, the movements that you, for ultrasound guided vascular access, you need a linear probe rather than a curvilinear probe. It has got lesser depth to it, but it's got higher frequency to it. Okay, and what's the advantage of sliding? Once you slide, you tend to find out the areas around your target marks. साइड में नर्व तो नहीं जा रही, कोई आर्टरी तो नहीं है, वेन की वजह में आर्टरी में तो नहीं जा रही. ठीक है, दिस इज द थिंग दैट यू लुक एट. ओके, triangular are most likely nerves, not a rule of thumb, most likely you have some idea. The sliding movement का ये फायदा आपको पता चल जाता है राइट लेफ्ट पे क्या है. ठीक है, then the movement is called compression. What will you find out in compression? You will know the difference between an artery, a vein, and a nerve. Can anybody tell me how the difference would be between those? Anyone?
Veins compressed.
Veins compressed रहेंगी, arteries? Arteries compressed होंगी, लेकिन जैसे ही compress करेंगे ना उनका pulsation visible हो जाएंगे. ठीक है, और nerves में क्या होगा? Nothing में कुछ नहीं. ठीक है, nerve जो ही compressible नहीं होगी. ठीक है? Okay, next. Probe movement of tilting. Tilting से क्या होगा? What will you identify in tilting? Tilting से क्या फायदा है? Extent, okay. What else? How will you differentiate between a nerve and a vein? Okay. तो tilting से क्या होगा? नहीं. Tilting से ये फायदा होता है, अब बोला था. Let's let it come on there. See the nerve will disappear and appear. A vessel will always appear. ठीक है, ये टिल्टिंग का फायदा होता है. मैं आपको हाथ पे भी करके दिखा दूंगा, मीडियन नर्व दिखाऊंगा आपको, आप देखिए कि अच्छा ये तो नजर आ रही है, अब नहीं आ रही है, नजर आ रही है, नहीं आ रही है. ओके, बेसिक प्रिंसिपल है, छोटी छोटी चीजें. And appear. Nerve will only appear on vertical 90 degrees, but it will disappear as you slide around. Okay? Rocking movement, again, rocking में भी यही होता है, आप एक्सटेंट देखते हैं राइट लेफ्ट का. ठीक है, और रोटेशन में क्या होगा? रॉकिंग देखिए. ठीक है, अब ये रोटेशन में क्या हो रहा है? एनीबडी कैन टेल रोटेशन में हो क्या है? नहीं, आप इससे लॉन्गिट्यूडिनल व्यू आप देख सकते हैं, लॉन्ग एक्सिस देख सकते हैं और शॉर्ट एक्सिस देख सकते हैं. ओके, दिस शॉर्ट एक्सिस, एक सेकेंड, दिस वन शॉर्ट एक्सिस. ओके, क्रॉस सेक्शन एंड लॉन्गिट्यूडिनल व्यू. ओके, जैसे ही आपने क्रॉस सेक्शन पे आपने प्रेस करके देखिए भाई ये आर्टरी नहीं है, इट्स अ वेन. यू जस्ट रोटेट द प्रोब एंड यू फाइंड द डिफरेंस बिटवीन and you find the target organ in longitudinal axis as well. सब करके दिखाएंगे हम लोग. ओके, नीडल विजुअलाइजेशन कैसे नजर आएगी नीडल जब आप प्रोब डालते हैं? व्हाट आर द प्रिंसिपल्स ऑफ नीडल विजुअलाइजेशन? ठीक है, आपकी नीडल है ना, इट्स लाइक अ मिरर. ठीक है, आपने फ्लैट रखा है the ultrasound waves are going to go down and reflect back. बहुत अच्छी नजर आएगी. एंगल आप स्टीपर करते रहेंगे तो आपको डिसअपियर हो जाएगी कि रिफ्लेक्शन कहीं और जा रही है साउंड वेव्स की. समझ रहे? नहीं समझे? ओके. अल्ट्रासाउंड वेव्स आर लाइक अ लाइट बीम, राइट? ये नीडल इज लाइक अ रिफ्लेक्टर. मिरर आपने टेढ़ा कर दिया, ठीक है? वो कौन सी शादी में रस्म करते हैं, मुंह दिखाई समथिंग है ना, वो मिरर वो टेढ़ा कर दिया, वो भाई एंगल नहीं बन रहा सर, ठीक है? तो ये मुंह दिखाई हो रही है नीडल की, सही है? तो अब ये एंगल चेंज कर देंगे तो आपको नहीं नजर आएगा, ठीक है? बेसिकली अल्ट्रासाउंड का प्रिंसिपल ये है कि लाइट जाएगी और रिफ्लेक्ट बैक टू द प्रोब होगी. जैसे रिफ्लेक्ट बैक टू द प्रोब होगी, प्रोब आइडेंटिफाई करता है कितना डिस्टेंस है, कितनी रिफ्लेक्शन हो रही है, अच्छी रिफ्लेक्शन हो रही है, नहीं हो रही है. रिफ्लेक्शन अच्छी नहीं होगी, एंगल बहुत ज़्यादा स्टीप रखा है आपने, मूव हो जाएगी, डिसअपियर हो जाएगी नीडल. ओके, बेसिक प्रिंसिपल है, बेसिक प्रिंसिपल. लोग कहते हैं यहाँ हमें नीडल नजर नहीं आती. भाई तुमने एंगल इतना वर्टिकल रखा है, क्या नजर आएगी इससे नीडल? ओके, नेक्स्ट.
This is will you why?
जी सर.
What is the purpose of doing this?
I will tell you. This is for IV ultrasound guided IV connection. This is what we're trying to. We're trying to establish the principles of needle visualization. Okay? So इसमें आपको अक्सर मीन्स डिफिकल्ट होती हैं, आपको नहीं नजर आ रही होती हैं, ठीक है? नहीं आप कैलकुलेट कर सकते हैं. अब अल्ट्रासाउंड